I'd like to extend my deepest gratitude to our panelists, YB Sim Zerzin, Member of Parliament from Bayan Baru, Mr. Azrul Khalib, CEO of Galen Center for Social and Health Policy, and Ms. Nadia Wan, former CEO of Thompson Hospital, Kota Damansara. Also a very warm welcome to Manvir Victor, an inspiring WHO patient advocate, and our moderator for this event. Finally, we would like to thank Prof. Tarini Loganathan, a public health or medical specialist specializing in health economics and a medical lecturer from Universiti Malaya. She will also be our panelist for today. I would also like to thank our media partners, FMT, Code Blue, and Sinchu Daily for being our media partners for this forum. So in Malaysia, we pride ourselves with a two-system healthcare system, balancing the public and private sector. However, in recent years, we've noticed a steep increase in private healthcare costs, and this poses genuine questions, like the sustainability and accessibility of healthcare, especially quality healthcare. It is irrefutable that private healthcare carries importance as they complement our public healthcare system by providing state-of-the-art and comfortable facilities, which in turn also reduces the strain on our public healthcare system. However, due to its rising costs, driven by medical inflation, specialist fees, and also operational overheads, we risk pushing these private healthcare beyond the reach of many Malaysians, especially those belonging in the middle income group. Which is why we are honored to have Ms. Nadia Wan, who was the former CEO of Thompson Hospital, to represent the private healthcare sector. We hope this forum will serve as a platform for meaningful discussions and to look into actionable solutions that can address these challenges. We believe that it will inspire collaborative efforts from stakeholders, advocates, and also policymakers for a more equitable and sustainable healthcare system for all Malaysians. Our goal must be to create a system where quality healthcare is accessible regardless of your background, income, and location. This initiative is completely student-led from the Universiti Malaya Student Union Faculty of Medicine Division in collaboration with Democrat Malaya and New Generation, which are student bodies. So I would also like to stress how gravely students heed this matter and their dedication to bring about real changes by having this forum. I would also like to extend my deepest gratitude to all the committee members who have worked very, very hard this past 1 month to bring this forum into fruition. Their dedication and perseverance in making today a reality. It is surely no simple feat to achieve, to organize and execute an event of this scale in such a timely manner. So please, ladies and gentlemen, please give a big round of applause for them. Additionally, I would like to thank all the public and participants for their support and encouragement towards the organizing committee in the execution of this event. With such a diverse range of representation in this forum, I am confident that today's discussion will yield actionable results. Thank you, and I look forward to the ideas that our distinguished panelists and audience will share today. Together, we can reimagine a healthcare system that balances equity with excellence. Thank you very much.
Thank you, Ms. Ashmita, for your insightful words. To kickstart the forum, we are honored to have a keynote address by our esteemed guest, Associate Professor Dr. Tarini Loganathan. Dr. Tarini is a public health medicine specialist with expertise in health economics. She is an Associate Professor of Global Health at the Department of Social and Preventive Medicine, University of Malaya. Her work focuses on health systems and policy, advancing universal health coverage, and addressing the social determinants of health for vulnerable populations, particularly migrants. Ladies and gentlemen, please join me in welcoming Associate Prof. Dr. Tavani Loganathan to the stage.
Hi, welcome everyone to Universiti Malaya. So I'm Dr. Tarani, and thank you so much, medical students, Medical Students Union, for inviting me for this session and for giving me this opportunity to give you all an overview on today's topic. Next slide. Today I will set the tone for the discussion. We'll talk about what is the Malaysian healthcare system like, our overall aim of universal health coverage, the rising healthcare costs in Malaysia, the implications on our healthcare system and all of us, and potential policy solutions. So this might be like a little bit of a lecture, but what is universal health coverage? Universal health coverage is our health system goal. It's highly aspirational. All nations in the world aim for this. I mean, health systems aim to cover all people in a country. Okay, services provided are the essential services as needed, an entire range of services, and also to protect the public from financial hardship while accessing healthcare. So we always look at who is covered, what services are covered, and are they protected? How much are they paying? Slide. So Malaysia is actually, since the 1980s, we have health policy analysts have claimed that we have achieved universal health coverage, and it's mainly through our public health system. We have a mixed public-private healthcare system in Malaysia. Public healthcare is about 50%. It is highly subsidized by government, funded mostly by taxation, government revenue. Okay? The services are the full range from promotive, preventive to curative, and the services of clinics and hospitals ranging from all the way towards a rural focus. So we go all the way to jungles and villages in the country. Okay? Healthcare is subsidized. The private healthcare system is a complementary system. It consists about 50% of our services. Services are basically curative and urban focused because it's market driven. Okay? This slide shows, maybe the slide before, private healthcare financed mostly by out-of-pocket payments in Malaysia. So I think most of y'all will be surprised here that 75% of private healthcare is financed by out-of-pocket payments. Insurance coverage, either private health insurance or employer subsidized insurance, is very low. It's a low contribution. And according to WHO and health policy analysts, having a very high out-of-pocket contribution towards healthcare, it's actually the most regressive way of payment because it puts the consumer at risk of financial hardship. You cannot plan for medical costs. If you incur costs, you need to seek services and it's very expensive. You may not go for it. You might have to borrow money, you use up your savings and incur poverty. Okay? Our healthcare system is mostly, 50% is financed by government. Okay? And as you see, our private household out-of-pocket is about 30%, a third. Okay? The next slide would show Malaysia with some of our comparable neighbors. So if you look at Thailand and Singapore, okay, so our out-of-pocket payment contribution is really high. Okay, so next slide. Okay, I would like to highlight research from colleague, recent DRPH graduate, who found that the effect of supplementary private health insurance in Malaysia is actually increasing out-of-pocket costs for all patients in Malaysia. So having health insurance, private health insurance, does not really protect you as much. Out-of-pocket costs actually are more, and the article goes on with all the reasons for that. Okay, and some of the key messages there was the importance of having a regulatory framework for insurance. Okay, next. Okay, so with the, this is a question for the audience. With the rising private health insurance charges, are we witnessing a healthcare system that excludes the vulnerable? Okay, so think about that. So with healthcare costs going up, I mean, we've been bombarded with all these worrying articles in the media over the last few months. It's been worrying. As consumers, in the public, it's worrying. Insurance rates going up for up to 40%, 40 to 70%. People have actually given up paying insurance, okay? And over the end of the year, BNM has stepped back and saying, no, maybe we should not actually go up that high, okay? So this is an issue of concern for all of us, okay? So this slide shows average medical inflation trends, okay? Globally, medical inflation is projected for about 10% in 2025. Malaysia is actually much higher than the global average. It's 15%. Okay, so I need to ask you as an audience to consider this and wonder why our medical infusion is so much higher than the global average. Please. So what are the drivers? So two of the drivers here, the rising cost of technology, the increase in consumption. Okay, so you know there are new drugs coming out, all the cancer medication, the diabetic medications, the new equipment that we have, it is expensive. Okay, we also have an aging population and NCDs are on the rise. But does this answer the full picture? Because, I mean, we are still higher than every other country, a lot of countries in the world. So what's going on? There's more to unpack here. Back. Yeah. We need to explore this further. Is it the profit-driven model or the insurance-driven model of pricing of private healthcare? Is it the insurance industry in Malaysia where it is limited players with less competition, so they do not offer the best premiums and packages for us as consumers, okay, with high costs and so on. So what are the implications of the higher costs, higher premiums to us? Okay. For the consumer itself, the public, some of them might give up on paying insurance because it doesn't make sense to them, it's too expensive. They may not be able to access healthcare as they want, right? So there is a widening gap. Right now, we talked about having a mixed public-private healthcare system. The poor are going to MOH with perceived lower quality of care, and the rich are going to the private healthcare. So this is not giving us choice on what to choose. Okay, out-of-pocket payments will go up. So if we have people who do not upgrade their insurance policies because they would have to upgrade their policies to get all the benefits, those people will incur more financial hardship. And to the public healthcare system, you would have more patients coming in, longer waiting times, and this would just increase the burden. And
steps towards solving these issues, then these students, they will be the one to inherit this problem. So kudos to them once again for doing this, right, for pulling this off. Now, let me introduce you to our panelists for what promises to be a very robust and very informative discussion later. I'm a little old-fashioned, so let's start with a lady. Nadia Wan. Nadia Wan was the Group CEO of TMC Life Sciences Berhad and CEO of the Thomson Hospital in Kota Damansara, a position she assumed in 2017 when she was at a certain age. I'm not going to tell you what, so then you're going to start guessing, right? Now, with a stellar academic background from Harvard College and the London School of Hygiene and Tropical Medicine, Nadia is passionate about transforming healthcare delivery. Now, she's a World Economic Forum Young Global Leader, Vice President of the Harvard Club of Malaysia, Director at the Institute of Corporate Directors Malaysia, and she balances her leadership roles with a love for travel, food exploration, and book collecting. So we can talk to her about books a little bit later. Right, next is YB Sim Zizen. Now, YB is a Malaysian politician, of course, an engineer, serving as the Member of Parliament for Bayan Baru since 2013. A former Deputy Minister of Agriculture and Agro-Based Industry between 2018 to 2020. Under Pakatan Harapan, he's a member of the Parliamentary Select Committee for International Affairs. Now, previously, he represented Pantai Juruja in the Penang State Assembly between 2008 and 2013 and served as a political secretary to the Prime Minister, Datuk Seri Anwar Ibrahim. As Deputy Strategic Director and Bayan Baru Division Chief of PKR, Mr. Sim is committed to advancing progressive policies and championing people's welfare. And then we have Prof. Taharani, who I have just really met just now, but you've already heard from her and her health economics, so I don't want to expand on that right now. And last, but definitely not least, on the other end of this panel is CEO and founder of the Galen Center, Azrul Khalib. Now, the Galen Center for Health and Social Policy has over 21 years of experience in health systems, HIV, AIDS, gender-based violence, public health policy. A molecular biologist by training, I believe, Azrul has contributed to key national and international reports, including Malaysia's National Strategic Plan on HIV and AIDS and the SDG Voluntary National Review. He has held positions with UNICEF, UNAIDS, IPPF, and IDEAS, and he co-founded the health news platform Code Blue. Now, he's very dedicated to shaping impactful healthcare policies and advancing social development. Now, it's very important for us to remember this, right? And for those who are live streaming now, and some of you who don't know, my name is Manvir Victor. I'm the chairman for Patient Safeties in Malaysia. I was a dialysis patient for 10 years, both in the public and private system, before having a transplant in the public system at HKL in 2012. I've since been trained by WHO with MSQH, and I do extensive work outside of Malaysia with several organizations like the British Medical Journal, the International Society of Nephrology, the International Society for Quality in Health, and many others, specifically on patient engagement and communication. Now, I've recently founded Vital Signs Asia, a healthcare portal for patients, by patient advocates, researchers, clinicians from the UK, Malaysia, Singapore, Thailand, India, Canada, the US, and Australia for now. Now, in Vital Signs, we will be sharing the best patient experiences and patient initiatives done by healthcare in various countries. So if you want to learn more about that, do visit our website. Now, for today, and this very, very interesting topic of rising cost of healthcare, let's talk a little bit about what you can expect and how we are going to do this, okay? Now, the first tenet of the Hippocratic Oath, which is what all doctors take when they become doctors, is primum non nocere, or first, do no harm. So, with that in mind, here is our first rule of this forum today. It's for these panelists, right? First, it is not their fault. And I am very, very serious about this, right? There is no blame to anyone here sitting on this panel. We are trying to unearth positive ways of getting out of this situation. And why is because they didn't create this situation that we are talking about today. That was done very, very many years ago, right? Not one single government or ministry or organization did this. It was a culmination of many, many things. And we are here not to nitpick who did what and when. It is a situation that all of us, including you in the audience and those of you who are live streaming from home, have inherited. We have inherited this problem. Now we are left with trying to solve it. This is just the state of our healthcare, right? Each of these panelists here have their own point of view and lens on the issue from their own perspective. So let's all respect that. You may disagree with that point of view, but do so with respect to the panelists and their opinions. That is rule number 2. Now, this is a university, and students are watching you and learning. So let's show them how proper discourse is done. Okay? This is not parliament. I'm sorry I had to say that. Okay, other than these rules, this session will begin with each panelist speaking for about 7 minutes on their point of view and experience. You may take notes. And after that, they will have 90 seconds to sum up and make 2 or 3 clear ideas or suggestions on what they have talked about. We will then proceed to the next panelists. And when the 4 esteemed speakers are done, I will then ask them to elaborate or discuss the points they made. And with the rest of the panel here, we are free to disagree and agree with each other. This session here on stage with us will take approximately 60 minutes. And then you will have the opportunity to ask your own questions of the panelists, either by using the microphones that we have staged there, or through the Slido system that we will share with you a little bit later. I have access to it here. We've allocated another 60 minutes to this. So let's have a robust, wonderful conversation as we want to do one thing. We want to flatten the rise of the healthcare. Flatten the rise. So that is our key thing here. Now, earlier I asked the panelists and they agreed to grant me the permission to use their first names, right, in order to be fair, to be concise, and to be accessible to everyone, right? So I'll be referring to them as Mr. Sim, Madam Nadia, Mr. Azrul, and Prof. Tarani, okay? Now, earlier we have decided on the sequence of speakers, and now it's my honor to invite the first panelist, Encik Azrul, to please speak. Thank you, sir.
Thank you, Manvir. Assalamualaikum warahmatullahi wabarakatuh, and a very good afternoon. Ladies and gentlemen, let me first thank the organizers for this kind invitation for us to be here, but also to have the guts to actually touch on this topic, which is actually arguably not a new topic. It has been going on for quite a while, and certainly last few months has just been the latest iteration of this discussion. In fact, as far back as last year, in fact, July, we were actually going on about this, especially since the Bank Negara regulations stipulated that there would be now co-payment and deductibles for new health and takaful products that would be coming in the year. So Manvir just now wished everybody Happy New Year, and you know, for a lot of people here, especially for those who are much older, the new year is not a very good one. And for many of us, we've received the insurance notice from insurers company announcing the increase of the premiums, but also with the introduction of co-payment and deductibles into existing cashless products that we currently hold for many of us. So for many of us, this discussion really is an ongoing one, and for which, thank you to Utusan Malaysia, which highlighted it back in November, thing blew up. And suddenly we were, sharing stories, talking about the different increases. And it is where we are today, and there's a lot of pointing fingers at who's to blame. And definitely the issue of healthcare inflation, which, to be honest, until this conversation, was really just seen as a background issue. I'm glad that because of this, we have an opportunity to not just talk about it, but also see about how we can address it so that we can ensure that there is equitable, affordable care for people who need healthcare in this country. So let me just start off with, first, by talking about how just now, Prof. Tarani mentioned just now the two-tier system that we have in Malaysia, which is that we have the public and private healthcare sector. Now, Malaysia is not like some other countries where there is just one healthcare system which is national. We have two, and there is public and private. Public, of course, the Ministry of Health, Ministry of Higher Education, Ministry of Defense, they run healthcare systems, but for the private sector, we have private hospitals, GP clinics, and a whole infrastructure that runs parallel with the public sector. Now, a lot of people will talk to you about how we need to continue to push for a system that is not commodifying, not looking at healthcare as a business, but the fact of the matter is that we have a two-tier system in Malaysia, and it is here to stay. The private healthcare system is not going anywhere. I can tell you right off, we have to talk about this, and we have to be realistic and pragmatic about it. It's not going to disappear overnight. It's not unless some upheaval in government or the government gets toppled and things get nationalized. It's not going to happen. There's going to be a private sector for healthcare in the future, and this is something that we need to deal with. It is very important for us to also acknowledge that in regards to this issue, there is no excess capacity in the public health system. Anybody who tells you that there is excess capacity, that we have extra nurses, doctors, hospitals, KKs, clinics, and so forth, in the public healthcare sector, which suddenly we can make use of for other purposes, that's not true. We are losing thousands of doctors, nurses by sometimes the month due to pressures, due to situations for which they are making their decision to leave the healthcare sector, to go to private or to even go to other countries. There is no excess capacity in the public healthcare system. We need to be aware of this. So we need to make sure that the private healthcare system works. We need to make it work for us. So I'm going to just mention a few points here that when you look at the healthcare burden for Malaysia, we are faced with practically around 3 main challenges that we have to look and consider when we're talking about these issues. Every year, we see an exponential growth in non-communicable diseases, which includes diabetes, cardiovascular disease, chronic kidney disease, and all of this comes with a price tag. When you consider the number of people who have diabetes in Malaysia, which is, I think, around 3.9 million people, or around 16% of the population. When you look at that and see that 1.2 million people need insulin, that in itself has a price tag. when we consider how many people are needing dialysis every day, needing to be treated for chronic kidney disease, renal failure, this is all with a price tag. So the fact of the matter is, for Malaysia, we are growing increasingly ill. More and more people are coming down with non-communicable diseases, and what was not mentioned and has not been emphasized enough, this is not talking about just the older group of people anymore. This is not those who are above the age of 50s, 60s, talking about having cardiovascular disease or kidney failure. No. We are seeing more and more incidents, cases that are appearing amongst the younger population. Before this, it was unheard of to hear of a 30-year-old getting a stroke. Now we are hearing about it. Kidney failure for those amongst those in the 30s. People who are diabetic, we now see childhood obesity resulting in more and more type 2 diabetes amongst children. Pediatric diabetes cases also on the increase. Secondly, is the growing population that we have, but also the needs. This is something that we need to actually consider. The fact that as we are going more into middle-income country, now we're becoming high-income country, our needs are greater due to a much more longer life expectancy. But let me tell you what the Deputy Health Minister, Datuk Lokanisman, told me recently, which I would like to repeat every time I speak in public, is that he mentioned that the last 8 years, so I think life expectancy is 76, and for males it's 2-year discount, so it's 74. The last 8 years of people who live in Malaysia is filled with pain and suffering. Why? Because they are basically living with non-communicable diseases, illness, needing even palliative care later on in life, but life period is very, very poor for many people. Third is the older population. A lot of people talk about how Malaysia is becoming an aging population. The fact of the matter is that Malaysia is not becoming an aging population in a distant future. We are already aged. If you look at the percentage of those who are aged above 60, it is already 11%. And the projection is in a couple of years' time, it's going to be 17%. So these are the burdens that a healthcare system needs to deal with. These are three big ones. There are many others, but these are the three main ones. So when we look at things like private health insurance, I'm not going to touch on public health insurance, public healthcare so much, but private health insurance. When you look at your insurance notice and you're being informed that your insurance is going to go up by premium, mine went up 40%, myself. A lot of people, especially those above the age of 60, saw their premiums increase to 200%. Not 70%, 40 to 70%, which you've seen in the media, but even as high as more than 200%. And the problem here is that it seems like more and more that health insurance is seemingly possibly marginalizing the vulnerable. Because if you are younger and you have less non-communicable disease or pre-existing conditions, then you are their preferred choice of policyholder. But if you're in the above age range or 50 and above, or you have a little bit of high cholesterol problem, or you have diabetes, pre-existing condition, you charge more. So this is what then happens, is that your premium really, really high up, and suddenly it's out of affordability. That is the discussion that we're having today, which is, can you pay your premium anymore? And a lot of people have decided that I'm going to terminate my policy because I can't afford to pay the monthly premiums. And so they are deciding not just for themselves, but also for their families, where parents are deciding, I'm going to sacrifice my own policies so that my children can continue to have protection through health insurance. So the problem here is, and I'm really going very simplistically in this intervention here, is that insurance is not in a vacuum, okay? insurance premiums, insurance coverage protections, and these increases do not operate in a vacuum. They're responding to ground realities, which is what is today's discussion about. And insurance tells us that private hospitals, for which the insurance is dependent on to access and to pay, to reimburse, private hospitals are significantly. They are also charging things that do not necessarily need to be charged. Things like, for example, the usage of wheelchairs. Wheelchairs, charges for heart monitor, bed linen, and so forth are being charged. The conversation today, if you look at hospital bills, how much of it is the specialist charge? How much of it are drug charges? And how much of it is hospital-related charges? And we find that based on industry research, 30% is specialist charges and drug charges. 70% of the hospital bill that you have, which is sometimes 16, 17, 18, 20 pages long, is unregulated. They can charge what they want, how much they want, even to the extent that the use of kidney dishes, stainless steel thing that you put instruments in and so forth, you can charge for the usage of that kidney dish as well. So it's unregulated. That 70% of the hospital bill today is unregulated, which is why we are having these conversations today about what is a reasonable and rational charge in a hospital bill. So I'm going to just end my intervention here with two recommendations from my end. Is that, first of all, I would like to echo what Prof. Tarani said just now, and I would like to add on a little bit. We need a national health insurance, definitely, but I would add on and say we need a national health and social insurance, which will cover both health and aging costs. Today, aging is not covered by anyone. Today, aging, people who are older, who are aged, it's a hope and a prayer. You are expected to cover private. Government is not assisting in terms of aged care. We need to fund aged care properly. And so we say, let's introduce a national health and social insurance which will cover health and aged care. Whether or not we can do it, we have to talk to the politicians now and see whether we can get it done. The second recommendation is that we need a new regulatory body to govern and to look at this issue of healthcare inflation. But most importantly, to regulate two things. One is the health insurance itself. Bank Negara is not going to like it that I say this, but we need to take it out from Bank Negara and put it into this new regulatory body for them to regulate. Because they need to act in the interests of patients and people, not just industry. Right now, we see Bank Negara acting in the interests of industry. So they will regulate health insurance. Second is that they will regulate the unregulated, which is the 70% of that hospital bill that I mentioned earlier. So we have a new regulatory body whose intention is to regulate what is not regulated so that we can get a grip on healthcare inflation. But I have to caution here, there is no magic bullet. There is no rabbit that you can pull from a hat and we'll be able to solve it immediately. This needs a firm determination, commitment that will be for a couple of years. Over to you, Manvir. Thank you.
Thank you so much, Azrul. Thank you. You brought up many good points. We'll get into that later. But I think you've set up Nadia very well because you're talking about private healthcare and the charges that are going on. So I hand it over to you, Nadia, to share your point of view on this.
Hello? Yes, thank you, Manvir. First of all, I'd like to thank the UM Students' Union for inviting me to come. I have a soft spot for UM. I was actually a Pusat Asasi science student and was going to head into your position before I was plucked out and given a scholarship, one of the last ones to get a scholarship to the US. So it's nice to be back in UM. Anyway, cost increases. I've seen a lot of conversation about why the inflation is high. And I just want to, I think my role here is just to shed some light, right, from the operator's perspective, the challenges that we face. Firstly, I think in terms of cost of supply, the situation post-COVID, there was actually a lack of stability in terms of medical device and drugs supply. And we were competing worldwide for this with our weak ringgit. So that actually also increased our cost base a little bit. Secondly was the wage cost increases. During COVID, actually, a lot of training was put on hold, which then led to now a shortage in healthcare workers. And the reopening of borders, particularly in Singapore and the Middle East, has led to a huge brain drain of our healthcare workforce, which has forced the private healthcare operators to actually have higher and higher wage increases, because healthcare is one of the very few industries in Malaysia that is protected from undermining of wages from foreign labor. We are not allowed in private healthcare to hire foreign doctors or nurses. And so it's a completely local workforce, and we have to compete, right? Because our nurses and doctors are in demand in many, many different markets. And so as a result, not many of you may know, but private hospitals actually offer a lot of scholarships for nursing and allied health students. We pay for their studies, we pay for their allowance, we pay for their flight ticket back home to Sabah and Sarawak. We invest a lot in education ongoingly, because even if you hire a nurse with a basic diploma, the shortage often happens in specialized areas, dialysis, OT, ICU, and the government doesn't have enough training spots. And so what happens is that the private hospitals actually set up their own training academy practically to have to train these nurses to work at a certain level, because we can't compromise on quality. And all of that has to be borne by the patient, unfortunately. You don't see it in your bill, but that's where the markups go. Thirdly, medical equipment and drugs innovation. Very simple example. Number one, you will see a lot of Da Vinci robots in town right now. And the reason is because for prostate cancer and gynecological surgery, robotic surgery is now the new standard of care. And I don't blame the patients, because who would want to have a big scar when they can have minimally invasive surgery with a robot? But that costs something. Secondly, Ozempic. Very expensive, very much in demand, not only by diabetic patients, but that is also, based on the existing research, the new standard of care, because it actually can reverse your diabetes and your complications. So the question here is that overheads are high, things cost a lot. We expect international standards from our private hospitals. Many of them have international accreditations. They can maintain them with no problem. So the cost actually, if you think about it, for what you get, we are not paying US or Australian prices. The cost is only reasonable because we have Malaysian salaries. Salaries are 30 to 36% of operating expenses in a hospital, by far the largest bucket of cost. And so, when we talk about charges, why are we charging for a lot of things? It's because these are the charges that are reimbursable, that will go towards supporting the overheads in terms of education, in terms of IT. Let's get into digital health, how expensive those systems are. We are not even affording the Epic that Singapore has rolled out. But for a simple HIS system, you are looking at no less than 6 to 8 million. And if you look at private hospital profits, of course, people focus on the number in the billions. But if you look at the percentages, if you look at gross profit, which is the profit that you get after you pay for all the supplies, that's 40%. By the time you minus out wages, administrative costs, by the way, the cost of insurance has gone up significantly since the decision with Columbia Asia holding hospitals vicariously liable. So our medical indemnity insurance has gone up. Depreciation and amortization of capital expenses is extremely high. So from 40, you go down to 11% net profit, which, I mean, you could argue because it's still a huge amount of money, but remember that investors are looking for their returns, and this is entirely privately funded by shareholders without any public subsidies. So why is private healthcare in the spotlight right now? The underinvestment in the public health sector has led to Malaysians more and more to rely on private healthcare system. We saw that in COVID. We tried sending all the COVID patients to public hospitals. It didn't work because you don't have any capacity to deal with it. The private healthcare sector has 1/3 of the hospital beds in the country, but accounts for half of the admissions. And so we come back to this question about cost. As you all know in health economics, you have the iron triangle of cost in healthcare. Access, cost, quality. And you can only pick 2 out of the 3. And so in private healthcare, we are maximizing or prioritizing access and quality because that's how the system was structured. Every healthcare system in the world has issues. When they look at this iron triangle and you look at national health insurance systems, how do they deal with the demand? They constrict supply, which is why you have wait times. We have health technology assessment units that decide on the value of interventions. Maybe you have closed loop systems where patients are only allowed to go to institutions within the loop. So that is very unlike private healthcare here, where with your insurance card, you can go to any institution and you can choose the service that you want. So you also have to think about the moral hazard that happens when someone else is paying the bill. A lot of Malaysians have employer-provided insurance and also individual insurance. And the number of policies actually increased post-COVID because obviously people were aware that, healthcare needs, and also because there was a backlog in the government. They couldn't get their treatment in government hospitals and procedures were delayed. I also want to clarify a misconception that private hospitals have differential costing for self-pay and insured patients. As a matter of fact, we only have one IT system that does the charging. And so it's very difficult to have one item have 2 prices. And we have thousands and thousands of storekeeping units or SKUs or items to be charged. What does happen is, number one, insurance will negotiate as a buyer to have discounts. But in the case of self-pay or insurance, usually the doctor and the patient choose how to manage their consumption, especially in a self-paying bill. I'll give you an example, cataracts. Insurance patients tend to choose to do cataract surgery under general anesthesia. Self-pay, local anesthesia. Why? It's half the price, but you don't have to see and hear the doctor cutting into your lens. Do I blame the patient? No, but that does drive consumption up. As a CEO, I don't have that much visibility across institutions in terms of pricing, but the insurers do. And this is something that I think we as healthcare providers can improve on in terms of looking at more closely at value-based care and linking procedures to outcomes and looking at incentives that actually link more to outcome-based interventions. The second part is addressing issues at primary care, which we all know that if you can manage an illness at the primary care level, it is infinitely cheaper than going to an expensive tertiary hospital. But private healthcare in Malaysia, there is no integration of care systems. By law, hospitals can't own GPs. So what do? We just focus on our higher end part of the value chain. There is no incentive for us to do primary and preventive care. And there's no funding for primary care in Malaysia anyway. 12 out of 13 primary care clinics in Malaysia are private clinics. And many of you here in the medical student program will probably, the trend is now, go out, do your housemanship, go out, start a clinic, sell it to a group like Care Clinics or Mediveron, make your money and actually do something other than medicine. That's what's happening now. So the reality is, even if you look at MOH data, they don't even report the number of visits in private primary care facilities. They don't have visibility. They regulate primary care separately from hospitals. Primary care is under Kesihatan Awam, hospitals is under Perubatan. I don't know why. There's no financing for primary care and step-down care, which will help you manage the cost. Sorry, I could go on, but I guess my time is up. But yeah, we can talk more about when you have questions later.
Yeah, thank you so much, Nadia. Lots of good points there, and we're talking about the profits, which is very important to fueling this conversation on the rise of healthcare. Now, very nicely, it goes to Mr. Sim now. Mr. Sim, as a member of parliament, and obviously you've got a lot of constituents, and your people, your researchers are finding out a little bit more about what's going on the ground for patients like myself and a lot of other people. Maybe you can allude to your point of view now.
Thank you. First of all, I would like to thank Universiti Malaya, Democrat and New Gen, and also the Faculty of Medicine for inviting me to this forum. And I very glad to share some of my perspective. I think it all started because recently I spoke up quite, what they call vocally on this rising healthcare and especially insurance. And we indeed, many of our PKR MPs were, forming a groups to pressure the government to do some reform on this rising healthcare costs as well as insurance premium. But first, I want to share some story with you first. Okay, I have 3 children. The first children were born 15 years ago. So when we're, before the delivery, I was discussing with my wife. I said, as a YB, we can get free healthcare service. Okay? So I said, hey, why not we send my wife to the hospital, the public hospital. My wife stared at me. Are you kidding me? First children, you want me to go to this GH? Why can't you spend a little bit money for your newborn? So I said, okay. Yes, darling, no problem. I sent her to this private hospital. I look at the bill, 2,000 ringgit. And another YB friend, he said, you stupid lah. I sent my wife to, same lah, we are same age, same children age. He said, I only spent 5 ringgit. You spent 2,000, bodoh. Okay. So I said, okay lah, never mind lah. I kena telan lah because of my wife, right? Okay. Second child was born later, 2 years later. Again, I said, hey, why not we go to GH? My wife said, hey, first child you give to private hospital. Second child, you must be fair. Send to private hospital. Okay. So send. I look at the bill. 4,000 ringgit. From 2,000 to 4,000. Only 2 years, same procedure, same thing, everything same hospital. 100% increase. The third child, I give up already. I don't want to talk about GH lah. I know what my wife will say. So I sent again to private hospital. 6,000 plus. Another 2 years later. So you can see the increment is like every year 50%. This is rising cost of private healthcare. Nadia? Not, no, Kujit. I want to ask Dr. Kujit, but he's not here lah. Okay, never mind. Okay, let's ask him later, okay? All right, and then there's this discrepancy because when we were trying to gather public information, a lot of people wrote email to us. There were about 400 people wrote emails to us. Yeah? So my team were trying to call them, ask questions, what happened, and etc. Some of very peculiar case, very glaring. Okay, husband and wife, same year, do cataract. Wife got company insurance. They were charged 6,000 ringgit per procedure. The husband didn't have retired, no insurance, were charged 3,000. 100% difference, 100%. All right? And then, there's not, I thought that this is only one case. And then I asked some of the doctors at hospital, they said, ini simpati, bagi discount. So he should be very bersyukur kerana sudah dapat insurance discount. No, dapat discount. He should be grateful. But I tell you, from what the Bank Negara statistic, okay, this is not true. Because the Bank Negara say, thank you. The Bank Negara say, dengue, out of 33,815 cases reported by Bank Negara and MOH, they give a briefing to all the MPs because we were very busy in the parliament. Sorry, kita busy lah. Okay, parliament has to be busy, right? If you don't busy, things doesn't get done. So we have to go and fight in the parliament. The difference, if you pay and claim out of pocket lah, you pay your own, you only pay 1,288 ringgit. But if you have insurance guarantee letter, you pay 4,978. 4 times difference. 4 times. 400%. And then if you are pneumonia, this is again bigger statistic, 53,188 cases. If you are pay and claim, 2,654 ringgit. If you pay by insurance, 6,859 ringgit. Glaring, 3 times different. So there's something problematic here. Okay, we see a problem. And of course, when we ask the insurance is not our problem. It's private hospital problem. Okay? When you ask private hospital, no, not my problem. It's government problem. Okay, when we ask the patient, it's government problem, insurance problem, private hospital problem. Everyone blame each other. But they don't look into it. So today, we are here not to blame people, okay? Most of the people will blame any politician problem. Politician create this problem. The government didn't do this. The MP sleep on the job. The MP only go and quarrel on stupid issues. Okay. So what I want to say here today, we are not going to blame anyone, including Dr. Kojit or Nadia or Azrul. We have to look into ourselves as well. First of all, as a Malaysian, we have a problem. We have NCD, obesity, not exercising. As a politician, I cannot say honest thing. I'm going to say honest thing now. The people will, they like politicians to say nice things, but I'm going to say the truth. The truth is, we didn't exercise enough. We eat a bit too much sugary, tambah, or too sweet, okay? And all kinds of other things, okay? All kinds of other things. We want not lemak, everything oily, must be salty, so that it actually it tastes good. Second thing, insurance company. You make billions, I have statistics here. You make billions, okay? I can show it. We did the research already. You make billions. Hospitals, you make billions also. Okay? A lot of money. You can say your profit margin 11%. My God, 11%. Do you know how much is 11%? I was there, the makcik there, 3%, 5% profit margin. You have 11% profit margin. So now, I think the government realized the problem. And it is true, Azrul said, there's no regulation of private hospital. Yes, it is true. I talked to Dr. Zul, the Ministry of Health. He said his hands is tied. He has no punca kuasa. It's true. That's why there's no regulation of HSS, hospital services and what they call the HSS, and also the consumables. They can charge whatever. For example, a pair of gloves. Some people complain to me. 20 ringgit a pair of gloves when they look at the medical bill. One box of this glove is 50 ringgit. But you charge a pair of gloves, 20 ringgit. Diapers, you can buy in this what they call in Tesco or whatever, maybe one big bag, 50 ringgit, but they charge one diapers 50 ringgit. Too much. So, what we are saying is now, we are not blaming you because private hospital, like it or not, they are private-driven, they are profit-driven. Yeah, we understand that. But there's a line between profitability and excessive profiteering. If the government can regulate an egg, for last 2 years ago, an egg rise from 40 cents to 50 cents. There's a whole country hue and cry. In parliament, gaduh sampai the roof wants to fall down because of 10 cents increase. And KPN, HDP, the MyCC can go in and investigate excessive profiteering. Why can't private hospital be regulated? The question. We are not finding fault. There's a line between profit and profiteering. This is what we are looking at. And then you must understand the patients, when they go in, they have no say. When you're half dead already, you're pingsan already, you are unconscious. You go to hospital, what can you do? You cannot argue every cent. Boleh ini berapa, boleh turun sikit boleh bagi discount. No more. You take whatever that is given to you. So I think there's a moral hazard here. And the hospital, the patients, they go in pingsan. I always say they go in pingsan. They come out, look at the bill, pingsan again. That's not right. So as a member of parliament, we are now pushing for regulation. We have to regulate. And I totally understand. And actually, private hospital in Malaysia, they are actually quite good okay? To be honest, they are good. We are not finding fault. They are good, they are robust, they have innovations, they are actually pushing the boundaries and attract a lot of medical tourism and all this. These are all good. But what we don't want is that it becomes unsustainable. Meaning, those people, they only serve the top 10%. Increasingly, they only serve the top 10%. And the 90% has no choice. They drop out from insurance. They cannot pay the out-of-pocket bill charges. They all go to the public hospital, GH. And GH will be overloaded. Now I was told the waiting time, some of the people complained to me. They wait 14 hours. 88 years old uncle got allergy, waited in the GH for 14 hours and got treated at 4 a.m. in the morning. That's how public hospitals are overloaded, because the private hospital is supposed to take certain responsibility, certain segment, so that public hospital can be free or lessen the burden. They must step up. And I hope public hospital must look at not the top 10%, the T5, T10 paying patient. They can, if they can, lower down their charges so that they can take 30% of the market share. The 30% market share, meaning it actually, you can make your profit from the scale, not only premium, top-notch paying patient. So hopefully, I think the minister is he's well aware. I had a conversation with him. He's well aware of what's going on. And the Prime Minister, from what I know, he is very determined. And he has actually instructed MOH to look into regulation. Okay? So I think that is good for a sustainable private healthcare. Private healthcare ecosystem, and by solving the private healthcare ecosystem, we actually help the public healthcare ecosystem. Thank you very much.
Thank you, Mr. Sim. As a patient myself, I need to make it clear that I didn't want to fall sick. I happened to fall sick. So I know in Malaysia we have this mindset of having two systems, private and public. But to the patient, wherever you are, it is a healthcare system. It is one healthcare system that can deliver help to you, right? One is more expensive than the other, one makes more profit than the other, is immaterial to the patient because that patient, regardless of who they are, is somebody's father, brother, sister, daughter. Those are lives that we're talking about. So healthcare is not a business, it's actually a profession of helping people. So I understand where people come from when you say 11%, 15%, whatever the percentage is. But we as patients look at it and say that when we peng san and walk into the hospital, we expect to come out and say, hey, that hospital saved me, not that hospital bankrupted me, right? So that's very important for people to understand. This is the industry, that's the business that we are in, saving lives. So right now, that brings it very nicely to Prof. Charani, who was earlier talking about health economics. Maybe you can allude to that a little bit about the social determinants of health, how people at scale need help as well, and how maybe if the private hospitals, the rise is not curtailed or not flattened, what will happen is people will drop out of the private hospital and end up going to the public, which again causes this huge backlog. And the backlog is one thing. You look at it as a figure, right? But it's actually a person. Every one decimal point is a person's life. This is where, from my point of view as a patient, that is a person's life. It's not a decimal point to me, right? Maybe, Prof. Tarani, I'll give it to you now.
So I've got the floor again. All of y'all have, all the panelists have made very interesting points. I come back to the health system's perspective. From a health system's perspective, we look at the country as a whole. We look at the nation. What is best for the nation? I mean, the health system's goal is for universal health coverage. So everyone gets the necessary care without getting into financial hardship. Basically, we're talking about everyone, okay? Not leaving anyone behind. That's the important thing, okay? Not people having to sell their property, go into debt just to access healthcare. So having out-of-pocket payments, having to pay directly for healthcare is really inequitable. It's the most regressive form of healthcare there is, okay? Because people will avoid getting necessary care, and that could cost lives and it could incur more cost burden at the end. Okay, so I mean, if you do not seek, for instance, preventative care, if there's no affordable primary care services, okay, so your diabetes may not be detected early, not treated properly, and then when you present to hospital with renal failure, what can you do? Okay, dialysis costs are really expensive. How do you pay for it? You may not be able to work. Okay, so how do you support yourself? How do you support your family? So it is a spectrum. It is not an end product, you know. So the outcome is not just at the hospital. It's an entire life course. And you're right, Manvir. You can't predict when you're going to get sick. No one can save adequately for healthcare because you can't predict it. I mean, when you're young, you think you live forever. Okay? In your 40s, then you realize, okay, there's some wear and tear here, and you know, people around you are falling sick and so on. But how do you plan? Okay? So the idea of saving for healthcare is really difficult. I mean, it's out of line for most of us out there. That's why there should be a prepayment mechanism for us to all contribute and a safety net, basically. So we have it in Malaysia with our public healthcare system. Okay? Unfortunately, that is being overstretched because of chronic underinvestment. Okay, our healthcare system is fantastic. I mean, basically, it's we built it up from scratch, from independence till now. The focus from the beginning has always been for equitable healthcare and leaving no one behind. But without adequate investment, it's in its current state. Private healthcare should be supplementary, okay? But the current way it is, with the aspirational nature of our society, I mean, we've developed to a certain extent. We want certain quality of care. We want to deliver our babies in private hospital or in nice surroundings and so on. I mean, I have worked in government hospitals, so I know what it's like. So most of us in the middle class would like nice surroundings, short waiting times, and so on. So the problem is when that becomes too unaffordable, and that will hit us, hit our patients and hit us. So this is an issue. I think the YB brought up a good point that we need regulation. Okay? Private healthcare is regulated, but barely. So the Private Healthcare Facilities Act, the 1998 Act, only regulates doctors' fees. So healthcare providers' fees are regulated. That's the only thing that's regulated, and that's why salaries are low in private hospitals. And you imagine everything else is very much high. Services are high, and so on, okay? So this is what that needs to be regulated. I think the health minister recently has talked about implementing DRGs, which is just a mechanism for costing. Okay, so that will allow benchmarking and standardized costing, cost ceilings for basic procedures, at least to start off somewhere, right? There is a lack of transparencies in hospital bills. We do not know sometimes if a consumer is given a bill, you don't know what you're being charged for. It might be gloves for 20 ringgit, right? Or 50 ringgit. Yeah? We do not know. So how do we ask, or how do we negotiate? We still have to pay, okay? Insurance agencies need to be regulated, okay? Currently, I think with the BNM sort of, the way they were talking, I mean, on increasing payments of premiums and co-shares, and it's all consumers that are being regulated. Yes, there might be moral hazard, but how much of moral hazard can it be? Because private health insurance only covers inpatient care, not outpatient care in Malaysia. So outpatient care in Malaysia, some of us are lucky enough to be covered by our employers, but not all of us. Okay? So you see our GP situation, the networks of GPs are not connected. We do not have a family doctor concept, you know, where one doctor treats you and makes sure you're well and does regular screenings and monitors your diabetes and hypertension, so outcomes are good. It doesn't happen. You go into a panel, you see a treatment, maybe you have a cap for your employer-based insurance. They charge you for that and send you back. So the next time you go into hospital is because you're sick. So you can't say it's a moral hazard for inpatient care, because the provider decides when you need to be admitted. Okay? When insurance pays for inpatient care only, then people are being admitted for medical screening. People are being admitted for outpatient treatments, you know, like daycare procedures. Those efficiencies can be controlled and are controlled in public facilities. Why can't it be controlled in private property? So there's other things that we could do as well. There are a lot of incentives and disincentives that to be given to private hospitals, to insurance companies, so to control raging prices. Yeah.
Thank you, Prof. Tarani. I think you brought up a couple of points, and you know, to your last one, those mechanisms that are put in place to bring the cost down. One is, of course, telehealth and telemedicine that is being done quite widely now to bring the cost down. Not widely enough. Not widely enough because I know the insurance companies like it because it brings costs down, but it's not properly, again, I think, not properly rolled out. But just before we go into that, I want to allude to something that you brought up, and Azrul as well, on universal healthcare, the necessity for universal healthcare. Now, my understanding of this after living in the UK, NHS has, when your salary is paid to you, 20% is deducted for your tax. A further 12% is deducted for your national insurance, which by right should go back into the system. It doesn't there. But is that what we are talking about when we come to universal healthcare? Some sort of a mechanism, not the percentages, but the mechanism, something similar to that? What do you think, Azrul?
Thanks, Manvir. Actually, it has been described that Malaysia, we already have technically universal healthcare. I mean, anybody can actually access the public healthcare system with the RM1, RM5 that we pay and be able to get the kind of quality care that you would want to be able to get. But you have access to that. And it doesn't depend on salaries or whatever. When you get that care is something else. That's what was described just now. But the issue here, and perhaps NHS is not the best of examples. NHS itself is going through tremendous trouble in sustainability, in looking towards ensuring that they're continuously able to be funded, but also to ensure that they're able to grow and develop with the existing pressures and burdens on the healthcare system. So what we need to do is learn from them based on what they have gone through to see what we can do better here. The difference between NHS and Malaysia, which is very, very clear, is that over there, as you mentioned just now, they have a form of contribution to a national health insurance. We don't. We depend on tax revenue to fund healthcare. And if you want to get an idea of how much revenue is collected, consider that we have a population of 33 million people in this country. Around 13 million, 14 million people work, but only 2.6 million pay tax. The majority of the population who work do not pay tax. So even if you collect sin tax, for example, which we collect annually from tobacco, gambling, cigarettes, if you just look at cigarettes and alcohol, it's around 5 billion. It's only 5 billion. This year's budget for health was what, 45 billion? So it's a fraction of that. So what we need to do right now is to find new funding. And for that, we need to look out of the box. And that's where we support the idea of having a national health and social insurance, which is collected through a means-tested approach, which looks at affordability, looks at income levels, but also make sure that people do not get left behind. Meaning those who cannot afford will be subsidized, but those who can pay more will pay more. And so we're able to fund the healthcare system in a way in which the collection for the national health insurance complements the existing allocation that we have right now. It doesn't substitute, it doesn't replace, it complements. So instead of talking about 45 billion, say from an initial collection, we get 20 billion, we are now talking about 65 billion. That will be a game changer. But the problem here is that nobody likes an additional tax on their paychecks. So it becomes a political problem as well. Because today, the RM1, RM5 system that we have since the 80s, that's from the 80s, that RM1, RM5, is no longer sustainable. In fact, we at the Galen Center argue, let's not talk about increasing RM1 to 10 ringgit, or RM5 to 50 ringgit. Let's stop that conversation. Let's just get rid of it. Why are we collecting RM1 and RM5 people at a point of care? It's not necessary. Let's talk about meaningful healthcare financing reforms, which raises the level of funding that's available. And for us, we do not need to collect RM1 and RM5 from the point of care. So we make that recommendation to get rid of that collection.
Very good point, Azru, because in the 1980s, when we first came up with this 1 ringgit and 5 ringgit, I don't know, maybe you can Google and find out what was the population of Malaysia then. It was probably 15 million, 20 million or whatever. Now it's at 33 million, so it becomes very unsustainable there. Now, Nadia, I'm just going to ask you to wear your economic hat on the funding process that, that can happen to help healthcare, you know, to bridge that gap. Because like we are all talking about earlier, these are lives at stake. You know, I know we're in that business, but it's that business of saving lives. So how do we, with your economic acumen?
I'll go back again. Private healthcare developed actually is supplementary. It's, if you can afford to pay, you get a choice, you can use. Now, if you're saying private healthcare industry, you have to shoulder the provide care to the population because the public system is underinvested. That is a whole different model. In which case, I agree that we need a national health insurance. Why? Number one, private insurance right now is structured based on a traditional way of doing it. But medical is not a catastrophic event, like fire or car accident. You know you're going to need this insurance. So you can't use a traditional way of risk assessment and pricing to do this. So national health insurance makes it mandatory for you to enroll into a risk pool so that you always have a sufficient population to bear the cost. If you allow private insurance to continue the way it's going, it's unsustainable because you're trying to insure something that by definition is uninsurable. Medical is something that will happen. It's not a catastrophic maybe will happen. So that's number one. Number two is how we do the regulation. Because let me tell you right now, if you want to regulate private healthcare services like you regulate an egg, it's gonna, how sure are you the government is going to be effective in implementing this regulation? Am I going to have to wait for somebody in MOH to say this is the price? Next time I want to import a new drug or a new equipment, how long do I have to wait for MOH to come up with the pricing so that I can go about my business? In the meantime, I tell the patient, cannot lah, have to wait. Because why? These things are coming into the market at a frequency and a volume that is different from a commodity like eggs. So how effective is the government going to be in regulating? Which is why most countries, they don't do a price cap. They just implement a sort of case mix system with a DRG and value-based care, right? What do? You look at the complexity of the case, you look at the demographic of the patient, and you say, for this particular case, this is roughly the ceiling for reimbursement. They are not capping each price of item that goes. And to answer your question, private hospital bills are very transparent. That's why you get 20, 25 pages of bills. Basically, every single item in there, you know what it is. But this fee-for-service way of charging is not how it works in developed countries for health systems that serve a majority of the population. Fee-for-service models are used in private healthcare systems that are supplementary to the main health system that is providing for the needs of the population. So you want to move to value-based healthcare, there's a lot of challenges that come into it. You need to change the regulation, right, from your medical laws, medical indemnity, because what does DRG mean? It means that for this particular diagnosis, this is the item that you use and this is the procedure. You don't go for Mercedes-Benz, okay, but we set the standard, this is a Proton Saga that everybody should accept. Don't come back and complain because this is what it is. This is what you're paying for. Right? Which works because you want to assure a certain standard of care. But in order to do that, how do you derive the cost of this Proton Saga? How do you define the model and make of this Proton Saga for this particular patient? There's a lot of work that goes into it. And on top of that, you need data. And I'm sorry to say that the digital health infrastructure in this country is poor. I mean, I was working in the COVID task force, and we were trying to find out how many people were in the KKs with COVID. And they couldn't even register patients because they didn't have internet, sufficient internet to even upload the data. Okay, and then I would go to the Makmal Kesehatan, and it took them 24 hours to churn out the data so that they just come up with the report the next day. So if you don't have data, how are you going to come up with all of these fancy benchmarks, DRG, costing, Because it's very simple to say, like, why is dengue paid out of pocket 1,002 versus 4,000? But actually, you have to go down to the details, like maybe this, if patients know they have to pay out of pocket, they go to public. So who pays out of pocket is the patient who only has a very mild dengue, who doesn't need ICU care. So that means that then when you look at it simplistically, the bill could have been smaller than what it should, than what a regular dengue patient who would have gone to a public hospital or used their insurance to pay. So there's a lot of subtleties and complexities behind healthcare costs. But we need to engage and understand and have a lot of transparency in terms of data of costing. And by the way, transparency of costing also needs to happen in the public sector, where right now, I would argue, they actually don't know how much it costs to provide care because everything is just consolidated in your budget. So people are always saying public healthcare is cheap. Why? Because they don't even have to account for the cost of providing that care. But we know that there is chronic underinvestment because the percentage that we pay, the percentage of GDP is still lower than what other countries in our category would spend.
Absolutely. Well, thank you for bringing up a lot of points there for us to discuss. And so, YB, I got to ask you next. I mean, she's brought up good points. Azru's brought up good points. What is the starting point of trying to solve this issue now? I mean, if you're talking about regulation, if you're talking about universal healthcare, what is the starting point that we need to look at, and how do we, as the Rakyat, maybe speak to all our MPs to push it up? I mean, we have some say at some point, I would assume. Patients, citizens of this country, we have a say. But what is the starting point of us getting there to flattening this curve?
Okay, if you ask about universal healthcare, actually, we actually have universal healthcare because all the public hospitals are all free. It covers everyone. But at the expense of the government for 45 billion a year. And actually, it's increasing every year about 3 to 5 billion. Okay? So actually, it's very expensive and maybe not sustainable. Yeah? Because we don't build more hospitals, we don't have the budget to build new hospitals, etc. So the question now is, do we need a national health insurance to cover everyone? Whether we can, everyone pay a little bit more, okay, from your salary or from other sources, and to make sure that we have a good coverage, basic coverage for if in terms of emergency or if you fall sick. This, you can blame the politician, because the politicians will be so afraid, because this is very, very, very unpopular, and the government can fall because of this. If there's no, I have to be very frank, if the current political situation of playing up everything, you know, everything government do is wrong, everything government wants to implement is wrong, and they will do a demonstration, they will do all kinds of things, then this thing will never happen. Because we need the parliament to have bipartisan support and commitment from the very top, not only the MPs, but also the people down there, including the cyber troopers. Because now what the political situation is that they will try to blame everything on the government, even its good policies. So I think this one, you can blame the politicians for not being able to push through meaningful reforms because of politics. So I think that's important. Okay, another thing I want to respond to what Nadia said. Nadia doesn't represent private hospital, you know, but I want to say one thing is, the private hospital has to answer us. Okay, you said that the prices are very transparent, everything is itemized, etc. But they have I haven't heard anything from private hospital answering Bank Negara's question. Why the dengue charges is 4 times higher if they are from insurance, if they claim insurance? Why there's a 3 times charges higher, 300% difference between this what they call pay for service and the letter of guarantee. This is where the problem is. Why there's such a huge difference? 300%, 400%. And why with my child 15 years ago, 50% every year, 100% every 2 years? Why there's such an increase of charges? I don't think the inflation is so high. So this is where the private hospital must answer to the rakyat. Okay? They must answer. That's why I want to challenge this, what do you call, what's the society? What's the Association of Public Hospital Malaysia? They must come out and explain to the rakyat, explain to the government. So I think what we want to say here is a sustainable, what do you call, a private healthcare system. No overcharging. You can have profits, no problem. But not profiteering. At the same time, there must be regulations. Okay? If there's this kind of 300% difference, 400% difference, regulators must come in to investigate what's going on. There must be able to be investigation on this.
I actually agree with you, IB, that we should have a separate body like what Astro said and have a financial ombudsman. Because right now, everything, all roads go back to MOH. And, you know, I think you need a separate body that understands both the health side and the commercial and the insurance side in order to be able to adjudicate. Because right now, that body doesn't exist. So if patients have a complaint, they write to MOH, Bagian Amalan, and that's it. But MOH, I think, to be fair to them, they have a lot of things under them. They are the service provider, they are the regulator, they are the policy maker. And so I think when it comes to this, but the one thing they don't really do is they do look at the commercial side of things. And so I think it would be good to have a financial ombudsman. And if you do roll out value-based care and DRGs, you will need this thing because somebody will have to adjudicate why this claim was accepted or denied. You know, why was this charged? Somebody has to be, but it has to be the right body that is making that decision. Because you can see in other countries, when you have people simply making that kind of decisions, it can cause a lot of hardship to the patients at the end of the day.
Absolutely. Go ahead, Azru.
I just wanted to quickly respond to what YVC mentioned just now about politicians as well. Let's not discount the power of engaging with the political process. I just wanted to point out that one of the reasons why we managed to get that cap of 10% agreement from Bank Negara for the insurance premiums, which is now capped to 10% over the next 3 years, is because members of parliament like YVC came forward and spoke and brought the voices of people to that process, which enabled for Bank Negara to take it seriously. And I cannot stress this enough, and I really feel that you should give him a round of applause. Seriously. Because the leadership shown is exactly what you need. Because you need people who are able to communicate the concerns of the public to that process in order for them to be taken seriously. Having said that though, it's always having said or but lah, right? We have to bear in mind though, that the out-of-pocket expenditures are on the increase. The latest data actually showed more than 40%. And now when we talk about insurance, actually to be honest, the healthcare insurance expenditure is around 8.3% only. More majority of it is actually the out-of-pocket payments which people are paying from cash, savings, gadai rumah, motor, kereta, EPF and all that. We want to make sure people reduce this and so that we could have more people who are able to be financially protected through insurance. And for me, I believe in having a system which protects everyone so that we can access both public and private when the time comes. It should not be limited to the people who only can afford to go to the private sector. Everybody should be able to have access. And that's where we have national health insurance there. But don't forget, 70% of the Malaysian population accesses the public healthcare system. 30% private. We cannot even afford even a 1% shift into the public from private to public because the public sector is already beyond capacity at the moment. And let's not kid ourselves by pretending otherwise. Over to you, Andre.
Thanks, Astro. Okay, so right now what we're going to do is we're going to open it up to the floor and on Slido. So if you've got a question, just grab a mic, please. There's a mic over there. I think there's another mic somewhere else. There's a couple of mics there. Please introduce yourself and tell us who you want to direct the question to, or is it everyone? Please go ahead, sir.
6 minutes. Okay. I don't think I'll need that. Thanks. Thank you, Mr. Chairman. I think my question, I have two short questions.
Sorry, your name, sir?
Oh, sorry, sir. Chan Chi Kun from
Citizens
Health Initiative. Yeah. It's a NGO, Health Advocacy NGO. Yeah, I have two short questions, and I'm afraid they'll both have to be addressed primarily to YB Sim, okay? Because he's from the legislative branch of the government, okay? Unfortunately, the executive branch is not represented here, okay, by KKM. Okay? So my two questions, again, very briefly. I'll just read it from the Slido that probably speeds it along. Okay, just give me a minute, okay?
I've got a couple of your questions here on the Slido. Are they the same?
Yeah, just give me a minute, yeah. Just give me a minute. Sorry about this, yeah. Okay. Okay. Yeah, the first question is, YB Sim, could you please help us understand why decision makers in KKM, okay, Kementerian Kesihatan Malaysia, okay, seemingly ignore overwhelming evidence that tax-funded healthcare system, okay, tax-funded, publicly provided healthcare, in other words, the kind of system that we have in Malaysia, okay, which is roughly modeled after the UK NHS, okay, the Bevan Beveridge type healthcare system, okay. Even though tax-funded, publicly provided healthcare systems, such as provided by KKM, okay, outperforms SHI. There's abundant evidence, okay. I can give references, okay, internationally, okay. So I'm really, Citizens Health Initiative is really quite perplexed, okay, as to why decision makers in KKM, okay, still lean towards social health insurance, SHI. Okay, my second question is, right, the Malaysian state at both federal and provincial level, state level, okay, is juggling multiple hats, okay, as firstly as funder and provider of public sector healthcare, KKM, for instance, okay, as a regulator, is the regulator of the many aspects of the healthcare system, and thirdly is also the preeminent investor, okay, in for-profit healthcare, for instance, Integrated Healthcare Holdings, okay, which is actually the second largest listed healthcare provider in the world after the Hospital Corporation of America. So we are hugely invested in for-profit commercial healthcare. And we're juggling multiple hats again. And of course, at the state level, again, we have a Kumpulan Perubatan Johor, okay, which is actually the largest chain of private hospitals. That's at the state level, okay. So there are these multiple hats which state government, federal and state governments are juggling, okay, at the same time, okay. So could YB Sim please comment on the inherent conflicts of interest here, okay, and how they might be dealt with? Thank you.
Thanks, John. We'll take another question. Next person, just introduce yourself.
Hi, I'm Ravinder. I'm an actuary and working in InsurTech. I've been in the insurance industry for 30 years. And I left the industry because not happy with what the industry is doing. And now I'm more a consumer advocate, trying to do the right things. First of all, I think the problem is there are too many private hospitals. In the last 5 years, we've had 7 new private hospitals and no government hospitals. In Kota Damansara, where I stay, there is the Thompson Hospital. Now there's Sunway Hospital just opened. Across the street, the Damansara Specialist Center. And then there is Desa Park City. And the whole of PJ has got only University Hospital. So why is the government and politicians allowing private hospitals? There should be a full stop to private hospitals. Only government hospitals. And yes, they can charge more than 1 ringgit and 5 ringgit. The next batch of government hospitals can be break even. So we have 3 tiers. You have the private hospitals who charge 30,000 for appendicitis with 2 days stay. My nephew just had that in Thompson Hospital. 30,000 for 2 days stay for appendicitis. Come on, you must be kidding me. Private hospitals, do you have government hospitals, 1 ringgit, 5 ringgit? The majority of B40 will not accept a change. Then you have a middle tier. You can call it Rakan KKM or whatever. They charge to break even. Then you will have those who can't afford private hospitals drop down. Those who want a faster time move up. That's one for the politicians. Second thing, we all, when we go to private hospitals, we know, we see the bill, we know it's a joke. You can't have an industry where every single person I know who's been to private hospitals laugh at the bill, but they don't do anything because the insurance company is paying. But what they don't realize is they are paying. It's not the insurance company. This is what has happened now. When the bill goes through the insurance company, the markup is even more because it includes profits, it includes expenses. Insurance bill is us paying in the end. And that's what's happening now. The 40 or 70% is because of this. So we lose out. It's not that we are saying we are benefiting when we self-pay. It's not. We are losing out because it goes, the markup is even bigger. And I will tell you one thing. Insurance, I tell you a secret, is pay as you go for medical insurance. So if you are 30 years old, you pay less than if you are 60 years old. And then if you are 70 years old, you pay more. So there will be a time you can't afford. It is a fact of life. Get used to it. When I was working in the corporate sector for 20 years, I was flying business class, sometimes even first class. Now I'm retired. It's okay to fly economy. It's past. Okay. The last thing I want to say, the fault is us. We are not taking care of our health. Okay? Simple things like grocers putting 40-50% the place serving junk food. We should put laws on this. We should stop them. Grocers cannot have so much of this. The next thing, last point. The last thing, buffet. Buffet is poison. When you pay 200 ringgit for a food buffet, you will overeat. And overeat is poison. We all do it. We should stop hotels from charging 200 ringgit for buffets, and we should take charge of our health. Nobody else.
Thank you. You brought up very good points. You brought up very good points on social determinants of health. When we want to pay 200 ringgit for a buffet, but we don't want to pay 200 ringgit for an insurance premium. Next question, please. Next, very quickly, please. Yeah. Then we'll take some answers from over here. Okay. Please go ahead.
Good afternoon. My name is Aga Abdul Sattar from North-South Initiative. And I have very small question to all panelists and all our friends, Malaysian friends who is living in the hall.
Sorry, your name again, sir? Your name again?
Aga Abdul Sattar from North-South Initiative.
Okay.
So how can we urgently confront the discrimination and inequality in Malaysia's healthcare system where migrants and refugees are forced to face life and death struggles due to unaffordable medical cost. What concrete actions can civil societies and influencers take right now to discriminate these barriers or to dismantle these barriers and guarantee equitable access to healthcare services for all, and why no healthcare research done on e-healing workers. So kindly provide clear, actionable solutions free from political rhetorics, please.
Thank you. So your question is basically on refugees, right?
Refugees and migrant workers.
Refugees and migrants' access to health is a human right. Okay, thank you. So the first three questions that we have, the first two were directed at you from Chan.
Okay, just quickly, I want to respond to Mr. Chan. On this tax-funded healthcare is better than SHI. I think it's pretty, I think the economists will agree to it. Yeah? I don't know, yeah? I think let the professionals answer this. But generally, I think Malaysia is tax-funded healthcare. However, the problem is whether this is sustainable. Because now the government is spending 45 billion, okay? And again, just now, Astro was saying, the tax base is only 2.6 million population pay tax. The rest generally don't pay tax. So it's very difficult. The burden of government is, and increasingly, everything, Malaysia has this, I'm sorry to say, and I have to speak my mind, and people will be angry with me because politicians are supposed to be saying all the nice things. But we have this, what do you call, subsidy mentality. Everything must be subsidized. Hospital, healthcare must be subsidized. Petrol must be subsidized. Diesel must be subsidized. Chicken, egg also must be subsidized. And paddy, rice, everything must be subsidized. So, if everything has to be subsidized, where the money from? There's no money. There's only limited money, and it's not enough for everyone. So now there's this moral dilemma. If you ask me as a government, I mean as an MP, or if you ask the Prime Minister who is the head of executive, they want to be good to everyone. They want to do everything subsidized, everything free better. But the reality is there's not enough money. That's why the Prime Minister now is very stressful. I don't envy him. He has a very stressful job because he has to cut subsidy on diesel, he has to cut subsidy on petrol, he has to cut subsidy on this, what do you call, TNB. TNB now, everyone is, making a big hoo-ha. Imagine if we say this, that we need to have universal health insurance or coverage, insurance. That will be another big political problem. So second question is conflict of interest in KKM. I think KKM understand this. In their white paper, the healthcare white paper, they understand that they are wearing multiple hats. However, to decouple it, I think it's a process of legislator. The legislation, the parliament must come in and have what to do, what to do. We must have a consensus how to go about it. So that's where I think we must play a role. And to be PAC, Public Accounts Committee, which I'm in, we are now pushing for a comprehensive study on private hospital and private and also insurance. We want to look at the whole ecosystem, and we will do recommendation to the government. And today, I see many people interested in these questions, and we will do a public hearing, okay? I will push for a public hearing. All right, so for you guys to come out with good ideas and whatever you want to say, please register your interest with my 3 staff over there. Can you stand up, please? Hui Ying, Jasmine there, my intern, former intern. and also Torrance. So we will register your interest so that we can email you or call you for this public hearing. Then on Ravin, insurance, you're talking about, can we break even, have a hospital that break even, pay high? Yes, I think KKM is now doing Rakan KKM. It's a premium economy. They are trying to give better care, better health, service, as well as paying the doctors and nurses better. So that is the plan. I think it's quite a doable plan. We hope they will be successful. I think this is a good initiative. We should support the minister for that kind of reform and the things that he wants to do. Let's support him. Let's support him, make it successful. Hopefully this can be a new model. And on this discrimination on migrants and refugees, I think the migrants and refugees are paying full fees, meaning there's no subsidy. Okay, the Malaysian public is subsidized. But migrants, but one thing that the government also feel burden is there's a lot of tunggakan. Tunggakan means they go, we take them in, they didn't pay, they left. Okay, so government actually, I forgot the figures, but it's to the millions, tens of millions of tunggakan in the, which migrant workers go in, they don't pay. Okay, they come out and then that's it. They say they cannot pay and government has to absorb the bill. So this is what is happening now. Okay, let's be fair to the government as well. Thank you.
Well, thank you. Next question. Please tell us who you are.
Sorry. Hi everyone. I'm Natasha. I've got a question for each panelist, if you don't mind. So for Ms. Nadia Wan, you mentioned that medical indemnity costs have been rising. Can we have a color on the percentage of this, and in your personal opinion, would this be driving behavior patterns of some areas of overcharging? For example, doing double tests because you don't want to get sued for not following SOPs. Was this what you meant when you mentioned that shifting to DRG requires a structural and one-to-one behavioral shift? Second question for Mr. Zafrul. The issue here is actually two-pronged, isn't it? So there is differentiated payments. Different people, you pay using insurances, different charges, out-of-pocket, different charges, and a separate matter, which is medical inflation. So to follow up on the former, in your opinion, does umbrella pricing, your DRG, BBO, VBH, do they have the potential to resolve differentiated pricings? And if not, what other elephants in the room that we have yet to address with regards to that? For Professor Tharani, say we assume that private hospitals are sandwiched with rising OPEX costs and price ceilings. Do you think that this could potentially push hospital operators, the private ones, to focus on the higher yielding, highly complex cases that cannot be parked under DRG? And given this scenario, wouldn't this demographic be pushed further onto the public hospitals? And for YB, apart from DRG pricing and whatever it is on the private side, on the public side, do you think there is untapped potentials? So for example, solving brain drain, long waiting times, patterns of like reactive care versus preventive care, and perhaps if we could consider, to build off from what the gentleman before me mentioned, a semi-subsidy, perhaps, of a university hospitals or whatever, for example, where you can divert the panels to be mostly your upcoming national health and social insurance, wherever, whenever that it comes. Thank you.
Okay, who wants to go with that, Nadia?
Okay, so to answer your question, so private hospitals in Malaysia are 100% specialist hospitals, meaning that all the doctors must be at registered with the National Specialist Registrar. What does that mean is that it's 100% tertiary care kind of situation. So now, when we have DRG, what is important is enforcing the clinical practice guidelines, because that's what it means. You have a standard approach towards treating a certain diagnosis for a certain cost. And I think there will be some implications towards the laws right now, especially for medical legal indemnity. For example, if you have all specialists in a hospital, the tendency is for them to do cross-referral because that is the standard of care. Because if there was a situation, and I've seen these cases go to court, where the judge asks, I mean, you're a cardiologist, You know, there was a diabetes issue. Why didn't you refer to the endocrinologist sitting next door to you? But you know, this kind of situation will drive the cost up. So in private hospitals, you don't have generalists managing the patient. What you have is you have a team of specialists managing the patient. And it is a very expensive way of providing care. So with DRG, if you impose, and again, it goes back to the philosophy, right? What it means to manage the cost is you have less choice. If you impose these clinical practice guidelines, then the practice of medicine needs to change the way it's being done in private right now, and that needs to be facilitated by changes in the regulations as well. Does that answer your question? Sorry, I didn't see you.
I will just have 2 points. First of all, concerning, you have to ask yourself the question of who owns the private hospitals? Who owns the private hospitals? You will notice that quite a number of them are GLCs, government-linked corporations or companies. Therefore, the question that we raised is it in the best interest of the government to address this problem? Because if it did, then it would have problems in terms of generating revenue, income, and profit. For the government also, there is a conflict of interest there. And we need to be able to look at it realistically. Who owns KPJ, which is the most expensive private hospital chain in Malaysia? Not Prince Court, which unfortunately gets the bad rap, but it's actually KPJ. Follow the money. See who owns the private hospitals. Then you will understand why there is a certain amount of reluctance also in terms of regulating on this issue. Second, on the question just now on the DRGs, again, and following up on what Nadia said just now, we need to look at the issue of DRGs realistically and also from a pragmatic point of view of whether or not they are going to be able to solve the problem. What is the problem? As far as I'm aware, the conversation concerning DRGs right now is really to address a cost problem. But it doesn't address the underlying problems that are leading towards increases. Would you believe it if I told you that the specialist charges, for example, that we currently use hasn't been changed for more than 20 years? GPs are still being paid the same rate that they have been for more than 20 years. Same thing with the specialists over there as well. So if we wanted to make sure that everybody gets paid fairly, are we going to accept that all of this will also need to be adjusted and regulated to suit the realistic expectations of people, and at the same time, lower the cost of healthcare? There's quite a number of issues here. And I wanted to just briefly mention here that Malaysia's private hospitals really don't get enough appreciation also. I mean, we bang on them all the time and, we kutuk-kutuk and everything, but the fact is that the private hospitals in Malaysia are full. They are very often full to capacity because other countries are coming to Malaysia to get treated. Patients from other countries, especially Indonesia, where it costs 3 times more to treat a simple case of, I think, cataracts just now was mentioned just now, compared to what they are paying in Jakarta. It is cheaper here because they're paying out of pocket, so they get that out of pocket price. So they're coming to Malaysia. So we're actually getting a good deal here, but at the same time, we also have to consider that it's beyond our affordability. It's great for the Indonesians who are rich and maybe, coming in from there, but for us in Malaysia, how are we going to ensure that we're able to afford the treatment that we need, afford the drugs, the therapeutics that are coming online today? We have to change the conversation from we cannot afford it to we can afford it. And right now, the DRG conversation is a good start, but there are many institutional issues that we need to address. Things like data, for example, which is very, very poor. We don't really honestly cost it properly in terms of the provision of treatment and care in the public healthcare system. We are still in an infancy with regards to digital health. Malaysia led digital health 15, 20 years ago. We were at the cutting edge, and then we fell behind. Today, we need to upgrade that. Are we making the investments needed to ensure that electronic medical records are able to be introduced? The health information systems are going to cost 60, 70 million. And the amount of money that's been allocated recently, 60 million, I think was mentioned, won't even begin to cut the amount of money that's going to be needed. So DRGs are not going to be it's not going to be the silver bullet, but it's a step in the right direction. But we just have to make sure we don't end up like America, which heavily utilizes DRGs for the purposes of costing healthcare. Thank you.
Absolutely, thanks. Your part to answer to her question, Prof. Tharani?
Azrul, for mentioning the elephant in the room. Yes. About DRGs, right? So I don't think we should be so afraid, or private hospitals should be so afraid of DRGs. DRGs is just a costing mechanism. Government hospitals, for your information, are already implementing DRGs.
Closer.
Hello? Yeah. Okay. They are already implementing DRGs. Okay, so I mean, government hospitals are also very complex and difficult to run, and we are doing it. I mean, it's happening. So the mechanism is just to understand what are the costs in the, of our services and rank them and benchmark what are the average. So in government hospitals, it's used to actually ask for more funding. Yeah, because previously, historically, the way we are funded, hospitals are funded.
Also, it actually shivers down all the doctors as well as the insurance companies. Insurance companies now actually charging doctors and hospitals much higher premiums on this. So I think it's a whole ecosystem. Sometimes the courts must also must understand that they cannot, we are not like America, that where we you know, you give a ruling of hundreds of millions to be given out. I think we have to manage that kind of ecosystem. All right, sorry.
No problem. I think one of the important things to talk about, and I'll go to you next, is the cost factor comes back down to the data. And we don't have enough data from hospitals. Hospitals have a very silo mentality. And what I mean by this is, there is a private hospital, one hospital, and the next hospital is within 5 kilometers. They run two different computer systems. You go to the first hospital, they register you. then you need to go to the second hospital to see somebody, you need to go there and register again. So this is the same hospital group. They don't even talk to each other, let alone the government or any other facility, right? So that is where we are lacking. I go to you right now, ma'am. Your name, please.
Hi, I'm Sean Sharif. I'm a patient advocate with Boleh Space. So actually, I have a few concerns that I want to address directly to YB. First thing is I feel really offended when you say the patients are not really taking care of themselves, because I have 3 different diseases that are idiopathic in nature. So essentially what it means is even doctors cannot figure out why I have these diseases. So since then I've had more diseases that I have to take care, up to the point where I go to the hospital on a weekly basis. And it does impact on my ability to do my work. So the first thing I would like the YB to take up is actually back in 2023, a group of patients advocates have come together, and we have actually provided a recommendation paper to the Health White Paper Committee. We've also had a session with Dr. Zaliha when she was the health minister back then, and she said that her people will contact us so that we can be directly involved in the Health White Paper. We as the end users, we as patients, we as OKUs. So we have a myriad of experiences, and we are also footing quite a lot of the medical bills. So it is only appropriate that we are at the table together with the people formulating future health policies of this country. That also includes in how the costing is formulated, and also what kind of charges are being provided to the people. Another thing, I get back to the, when you say about people needing to be more, to lead a better health lifestyle, I want to point out that our poverty wage is really, really low. People don't have the money to actually pay for the nutritious food. They don't have time to actually go exercise because they have to undertake 2 to 3 jobs for them to survive. So these are the things that are the social determinants of health that you must take into account when you come up with any health-related policy making. Okay, thank you.
Thank you so much for your question. Next question. Let's take that while YB is going through that notes.
Hello, my name is Nabil from Menchakna. I'm curious about, I'm for the National Health and Social Insurance, but one of the things is, should EPF and SOCSO be involved in the conversation, since both of the organizations align a lot with the National Health and also Social Insurance? And second is, if we have the national insurance, there's going to be a lot of pool of money. Is there a mechanism by the government to ensure that there's no leakages of the money being used for other purposes? For example, since we have history of sponsoring vanity projects for a social issue, are there a mechanism for that? Okay, thank you.
Thank you. Very interesting. Next please. Yeah.
Hi, Alifa from Code Blue. My question is for Nadia, if you can answer this. It's about DRG. So you mentioned a few times just now that DRG requires a lot of data and robust case mix systems. So do private hospitals have case mix systems? And if benchmarking DRG against Rakan KKM is realistic? Also, do you think private hospitals are ready to implement DRG by June as suggested by Dr. Zul? Thank you.
Nadia, you've got that question? Do you want to take that first? Could you repeat that question?
Was the question like, are we ready? Was that the question?
So firstly, if you could maybe share private hospitals' point of view on the DRG system, if you have case mix systems to begin with,
There isn't any case mix system. I don't think there's any hospital, public or private in Malaysia, that has actually rolled it out. And even EMR is still not there. That's why I said the digital health infrastructure is going to be a huge challenge for this.
And so the suggestion to benchmark DRG against Rakan KKM, do you think that's realistic given your experience handling COVID, etc.?
Sorry, could you repeat that part?
Yeah, so do you think DRG, benchmarking DRG against Rakan KKM is realistic?
Is it realistic to benchmark DRG against Rakan KKM?
Yeah.
Oh, wow. Against Rakan KKM.
I think Rakan KKM, the way I understand it, is a way of them piloting how this thing is going to work out in terms of provision of care that is not completely taxpayer funded, and enforcing the CPGs, and then collecting that data. Because right now, as I said, there is no clear cost data in terms of provision in the public hospitals. So you right now would have two sources of data. Insurance will have cost data, the private insurers, and with Rakan KKM, they will be able to develop that based on CPG, because private insurers' cost data is a fee-for-service based model. It's not imposed sort of like categorizations or case mix. So there is a lack of data right now, data for DRGs, because we haven't got any hospital who has really 100% implemented it, followed the CPGs, and then we have the cost data in order to come up with those benchmarks.
So is June a good timeline, an achievable timeline to implement this DRG, do you think?
So I think that's why we need to do more consultation, but I think with Rakan KKM, that's a good start to actually start collecting that data, and private hospitals need to be also working towards implementing these systems so that they can collect the cost data. And everybody's mindset needs to be, we can no longer stay with fee-for-service, because fee-for-service is for supplementary private healthcare that is actually meant to be optional to a health system for the population. So that mentality needs to change. And so with that, I think then they would be working towards implementing the systems and processes for us to get there.
Okay, I think I want to respond on the first question about the lifestyle. And so, like what I say is that generally, I think Malaysians, we are the highest in terms of obesity. We are, I think, the highest in Asia Pacific. Diabetes, also the highest. Okay? And including me, I'm also a little bit obese already. So I also blame myself for not doing the right thing, do more exercise, etc. I mean, these are general advice to everyone. I know everyone has different circumstances. Some have to work 2 jobs, 3 jobs. And this is not, it is very difficult, I know. But I think we all must be responsible to take care of ourselves. Then for your NGO, of course, we want you guys to come out and give us input. I think government, this healthcare reform is going to be generational. It's not going to happen in 2 years' time. This is going to take 10 years, 15 years. And the fight is very long. And every one of us today, here in this room, please fight together for the next 15 years. Be ready for it. Okay? Seriously, the Americans has been fighting. Recently, what happened in America? The healthcare is really unaffordable. They fight for many, many years, and it's not successful. Okay, and then in many parts of the world, everyone is fighting this kind of, sorry to say, big pharma, big insurers, and that kind of cost escalation. So I think we must be vigilant. Second, I think it's also on EPF, SOCSO, and NHI. NHI, I think it is written in the healthcare white paper, but whether the government will be implementing it or not, it depends on the consensus and the, what you call, society. Society must discuss and push for it. And we as a member of parliament, we always constantly listen to you guys. If the society is ready for it and feel there's a need of it, then we'll push for it, and then we will have to have a a bipartisan, all of society, whole of society, to agree with it, because this is going to have a long implication, very big, huge implication, and we must be ready in a whole society manner. And of course, if we do this kind of thing, there must be, no more leakages. It must be run professionally. It has to have very, very stringent and what they call oversight, or else it will be back to square one, squandered all the money.
Thanks, Manveer. Just wanted to quickly mention that this is where I'm coming from. When it comes to people with diabetes or chronic kidney disease, hypertension, living with stroke or a rare disease, I am trying to make sure that we can work towards a future where you can get the treatment that you need, the care that you need, at the quality that we need to be able to expect, and leave no one behind. It's not rhetoric. It's something that we should work towards, and we should not be blaming patients on the worst days of their lives, that suddenly it's because of them that they've landed themselves in this mess. That's a belakang kira punya story. We are wanting to ensure that treatment is available for you to be able to do the best that you can and be able to access the best that the government, the people, country can offer a person who is in need of medical treatment. We should always work towards that. And we work with quite a number of patient groups, and we always believe in supporting that. I wanted to just mention two things. One is that we as policyholders also, we need to also be aware of what goes into the billing as well. The insurance industry says that policyholders are indulging in buffet table syndrome, which is basically a situation where, because you are cashless, you are going for all the diagnostic tests, you're going for the different screenings, things that you don't need, but because I already paid it for 10 years, 15 years, I want to make the full use of my medical card, and I'm paying for this. And therefore, the private hospitals charge accordingly. We also need to be cognizant of that as well. There is a problem, and we need to pay attention to the bill. Just because insurance is paying for it, we tutup mata and say, oh, somebody else is paying for it. We need to be aware, and we need to care about that too, because that's the only way we're going to get changes made. The second point is concerning SOCSO and EPF. In Singapore, when they first introduced the health insurance over there, they went through the CPF, the Central Provident Fund. So we could take a similar approach where on top of EPF, which we already have, we can increase the amount of contribution and make use of that to collect the amount of money necessary without introducing a new form of tax. Because that's what Singapore did, which is make use of an existing mechanism. But the fact is, what was mentioned just now by our colleague just now, is that we are concerned about where does the money go. And the fact is that there is a trust deficit in Malaysia. We do not trust where the money goes. And so what we need is probably a new legislation that guarantees that this money is collected, earmarked, gatekept, and spent for the purposes that it's intended. So thank you for that suggestion just now, because that is one of the issues that we are trying to bring forward to make use of existing mechanisms to introduce national health and social insurance. Thank you.
Very, very good points. Like in Singapore, like you were just alluding to, from CPF, it started there, but then now they've gone to MediShield. And MediShield takes care of the insurance for the people there, right? And so they are gatekeeping it, like you said. They are professional, but the reason they're able to do that is because they have the data. They know exactly how much you need to spend and where you need to spend it. Yeah, sir, next question, please.
Hi, my name is Aaron. So I'll just keep this short. Should Malaysia adopt precision medicine and pharmacogenomics to cut healthcare costs, reduce adverse reactions, and improve outcomes? So what's the best approach for, I present this to all the panels. So.
Okay, very good question, very good question. Singapore has done something with that. Next gentleman, please.
Good evening. I'm Dr. Baines, Dr. Baines. I'm a physiotherapist with 45 years of practice, and I've seen a lot of things happening in Malaysia. Well, I should congratulate the young who have come up with this idea of having a good discussion today about health. Yes, we are aging, and I have seen aging people coming to my clinic, and they have to fork out a lot of money from their pockets. It's not the aged who is giving the money, it's the young who give the money, unfortunately. So we should learn from the neighboring countries. We have India, for instance. The insurance after the age of 70 is been given by the government of a certain value. So we can just Google around and see what India has for the aging population. And here, Malaysia, undoubtedly is a rich country. We can do wonders. But unfortunately, money has been squandered here and there. What I would like to say here is this, that the SST has been imposed on physiotherapy. Look at the direction of our government. Physiotherapy is a needed an entity, health entity in this country, where every person who is aging will need physio one day. And SST has been imposed 6%. People who are not able to move after strokes, people who are bedridden, they have a big hole in their pockets, and SST is put on this. I'm sure SST, which is coming from different organizations and different businesses, is making the country rich enough. So I feel the government should really look into this. And this act under which we have developed Act 774, which has no exemption of SST. So we are fighting for it. YB, we may want to take this ahead and see how we can get this exempted. I have spoken to many ministers as well, and also we have addressed this to the PMX, but until now we have not got any answers. So is it necessary that we have to, the public have to take out the money for extra 6% over the expenses of repeated expenses, not one time? You may have to see a physio maybe 3 months, for 4 months, 5 months. And just imagine the amount of money that you're going to pay. Thank you very much.
Thank you. We'll do that bunch of questions from the people over there, and then we'll close and we'll go to the Slido as well. So please go ahead.
Hello, I'm Logan. I'm an actuary. I've worked in the industry for 12 years, and now I'm an independent consultant, so I can speak without fear. I would like to challenge the view that it's a pricing issue. When it comes to insurance, my view is it's a design issue. Number one, when it comes to distribution of insurance in Malaysia, we rely on an agency. I think this is an inadequate model. About 40% of our premiums goes towards commissions. And if you may notice, agencies are run, I'm sorry to agents over here, it's run on a MLM-like model where people are incentivized with trips, lavish trips and all that, which comes from premiums. So that's number two. Number three is agents typically are not, yes, they do have their professional advisory and all that, but they are not operating on a fee-for-service model. So this is different from the doctor's fee-for-service. So when it's commission basis, they are incentivized by the size of your premiums, so there's a product push incentive. And then there is also the issue of anti-selection, because medical insurance, as Nadia rightfully said, is not exactly an insurable risk. So what happens is people who buy individual insurance tend to have higher risk, which increases the premiums overall, compared to employer-sponsored insurance. SME group insurance is very, very cheap. I buy it for my company at 400 ringgit per year per member, not per month. And the awareness is extremely low. And then the other point is awareness of health insurance options are abysmally low, very, very bad in Malaysia, I'm so sorry to say. So this issue about co-payment is very wrongly understood. By all means, if you can pay a 1,000 ringgit deductible and you get a 20-30% reduction in your premiums, you should. Honestly, I myself, I rely on my employer, my own company insurance, and I get a 30,000 deductible. I have a 70% discount. So this education, and then, no problem. And then critical illness insurance is also not well understood. Critical illness is a very interesting space where, Sorry? 35. So critical illness insurance, you have a lot of different options. You have late critical illness, comprehensive critical illness covers, but I've designed these products and the sales are very, very low simply because the insurance agents don't understand it and they're not able to explain it. So, and the cost for providing these types of insurance is very much lower, and it will lend much better, it will help our financing system. So I just want to surface these issues so that we can have these, these things addressed as well. Thank you.
Well, thank you very much. Very good points you brought up about insurance. Unfortunately, there's nobody from the insurance industry here to be able to answer our questions as well. Next gentleman, please.
Hi, good evening. My name is Satya. I represent, or I come from a third-party administrator, Dr. Bala. Hi. So just a few things from my observation of having been a TPA for the past 15 years. So just for those who might not know, TPAs, we sit in between payers and hospitals. So we are the ones who sort of issue the guarantee letters. And I think what's been discussed and beaten a lot is that there's overutilization and over-servicing. And there's a lot of attention being put on the hospitals overutilizing the services, but no one really wants to talk about patients overutilizing the services, the buffet syndrome. Azrul mentioned just now, people say, I've been paying premiums for the past 10 years, I should get what I've paid back. But people fail to understand that when they go to a hospital, they're actually putting themselves at risk, because a hospital is a place for sick people. We've had cases where someone goes to the hospital for dengue, but they die 6 months later due to total organ failure, right? So and they don't just die from organ failure, they die organ failure because of pneumonia. So there's a lot of sort of side effects that people need to think. So what people need to really think about is, what can my GP do for me to help me stay healthy? People must go back to their GP and talk to their GPs instead of going to the GPs for the purpose of getting referral letters. Just the other day at a New Year's party, I was talking to a bunch of accountants who audit books for insurers, and they were talking about how they just go to the GP, tell the GP, I want to see this specialist in this hospital. The GP charges them $10, they take the referral letter and they go to the hospital. That's so wrong, right? And then hospitals on the other side, we see the bills for hospitals charging for welcome packages. Why? Like, you go to the patient, you give the patient a welcome package, and then you charge them for it? That's not fair, right? And patients are happy to accept that package because their employer or their insurer is paying for it. That's completely not fair. And the issue, Nadia brought up for cataract, if you're insured, you go under GA. If you're out of pocket, you go under local anesthesia. But what about the risks associated with GA? Patients are not advised on the risks associated. So it's huge, right? So I think at the core must always be the patient safety before anything else. Thank you.
Thank you. Next, sir.
Thank you. This has been a great session. I am Professor John George. I am ex-professor of radiology in UMMC and also the proposer to JPA for the UMSC, University Malaya Specialist Center, which was granted to us. I'm the ex-chairman of Government Doctors MMA, national chairman. So I've actually written extensively on a national insurance system. I've got like a whole white paper on this as well. But where I see, I like YB's point about the fact that this is a political issue about introducing a new fee. So we have to be careful about the Singapore system of using CPF because they're actually using the funds that the patient have. But my concept is a bit different, and I've been trying to propose this, and that is when you contribute to EPF, which everyone does, that money is already there. The question is, can you take 10 ringgit, 20 ringgit, 30 ringgit out of 15 million contributors per month, put it into a separate account so that it's the same money, but there are two ways of investing. One is you're saving for the future and getting an interest. The second, which is very vital, is using the fund to buy that collective insurance for everyone. So now what happens is your 20 or 30 ringgit is not to get 6%, but to cover 100,000, to cover 150,000 of out-of-pocket payments in the government, because in the government you need to cover prosthesis, you may need to cover certain things which the government is not covering. At the same time, the government wants to build hospitals, $200 million hospitals. I'm not sure how many EPF people we have, but we have about 15 million, I think, EPF payers. So 10 ringgit means per month you're collecting 150 million. How much does a hospital cost? 300 million. In 2 months, you will have one hospital, new hospital. So this is a good system without asking people to pay more, but to utilize EPF buying the insurance. And of course, you're going to still have your national insurance system, your sin tax, whatever, coming into it, but EPF will be one way of getting the money into the system. The DRG, I want to inform all of you that the government is serious about it. I sit on the fee schedule of MMA, and we are working with Professor Said Al-Junaid, who has already done this system. He actually did all the work and groundwork for this in 2000, but the government didn't implement it, but instead Indonesia and many countries adopted the DRG system, and they are using it. 3,000 hospitals in Indonesia use the DRG system, which is actually founded by our own professor, UKM professor. So he has been called to look into the DRG system. And I want to correct one thing that was mentioned, that the government hospitals don't have case mix. You are right, professor, because you keep saying they don't have. They do a good job. They have a good job on case mix, and they use case mix very well. So, and Professor Said was involved in this, and in fact, he has created a grouper system and computer system called MyDRG, MYDRG, for Malaysia as well. So he is well ahead, and he'll be called, and MMA is working with him. Thank you for bringing up the point. For 30 years, GP rates have not gone up, and for 12 years, specialist rates have not gone up. So one thing we mentioned in the DRG, don't discount the doctor's rates, because we already are discounted for so many years. Thank you.
Thank you. Sorry, what was your name again, sir? Professor?
Dr. John George.
Dr. John George, okay. Fantastic. I like your first idea of, you're saying from the EPF contribution that is already there, a small allocation is made to another account for insurance purchase for the user, right? For the user, something like that. Okay, and the final question, your question,
Hi, thanks for giving me the chance to ask the question. My name is Morgan. I'm actually a PhD candidate third year PhD candidate from Monash, and I'm currently working on a thesis looking at medicine price controls in Malaysia. So as we know that since 2019, the government is trying to bring up medicine price controls to bring down the medicine cost and so on. But one of my genuine questions to YB, do you have any idea that what are the current progress on promoting medicine price transparency or pricing controls in the Malaysian context? Yeah, that's all my question.
Okay, thank you so much. And we'll take one more final question, and then the panel will answer.
Thank you very much, panelists. I'm Dr. Bala. I'm a GP. I see a lot of people talk about GPs. So now the GP itself is over here. So I don't want to take so much of our time. Thank you so much to all the panelists, because here I actually have bring out lots of points, okay? And our Madam Nadia have mentioned about care clinics and everything. So of course, whenever we run the 100 clinics, and we are the actual primary care, and we are the bastions of the healthcare of Malaysia. But sad to say, our Malaysian government is not looking at us. So lots of people talk about the fees. Thank you, Prof. Of course, we are still, after 30 years, being paid peanuts, all right? Okay, put it that side. And I'd like to ask one question to our professor, all right? See, all these things, okay, when we talk about healthcare,
I'm one of the panelists also on the, the white paper, blah, blah, and everything. The 4 pillars, the main pillar is about preventive healthcare. At this point, I just want to ask the government, because our YB is sitting there, are we really invest in our Malaysian healthcare, Malaysians' health? Because at these points, we are talking so much of a ill industry. The wellness industry is nobody talking about. Insurance agents, insurance companies not bothered about wellness. Okay, I'll put it up very clear. Because that's where the fundamentals are. We are talking about fighting for 15 years. YB, you are talking about 15 years to fight. Yes, 15 years, we need to fight now. Start teaching from our school students how to eat, how to do. And all these things starts from minister. Start from the government. The government need to start out the whole entire thing. I like to point one country, a simple country. I don't know, first of all, our country, what is the statistics now? Are we underdeveloped, developing, or already developed? So we have to decide on that. Because when I talk about this country, Japan, they have given so much of emphasis. Every citizen of them, they must compulsory, under the government budget, must do minimum 1 times a healthcare checkup. That means their NHS, they have all the records of their each citizens now. So anything kickstarts, anything they find out, they know very well how to handle the situation as early as possible. Not like in Malaysia, we see our patients coming only after their ankle gets swollen up. So all these things start with 2 things only, simple. One, it's our budget, okay, YB. Okay, whatever we can say and done, we don't have the budgets, we cannot talk. So for many years, our GDP, what has been sanctioned for MOH is still under the 5%. So when it comes to 10%, I think everything, whatever you say, it will become materialized. That's one thing. Second thing, the CEO who runs the MOH, I'll be suggest, it can be joke, probably Tony Fernandez can do a better job. Because you see, okay, when you can run a budget airline, why can't it be runs a budget hospital? Thank you.
Well, Tony Fernandez running our healthcare. Well, it's an interesting comment, Dr. Bala. I agree with a lot what you say, because a lot of health systems in the world call themselves the Ministry of Health. They are not the Ministry of Health. They're actually the Ministry of Sick, because they only take care of the sick people. When you fall sick, they take care of you. When you're healthy, they don't promote health, right? So, but let's address some of the questions that there. I'm going to go to you first, Professor Tarani, because they were asking about pharmacogenomics, and then, of course, Dr. Bala's question about preventative medicine. So that sort of like links up. Maybe you can talk about that.
Yeah, and also someone asked about how we're regulating prices for medicines and so on. So pharmacoeconomics and all plays a role. Okay, MOH does it, and you can hear me. Okay, they do it, but maybe it's not good enough, because medications are coming into the country at such a rate. New drugs are coming in all the time. Okay, at the public facilities, there must be a decision made what government is willing to pay for. So that is based on cost effectiveness. It should be. Is it something that we are willing to pay, or is it really an effective treatment? Is the cost what we are willing to pay, the government is willing to pay? So this kind of decisions we have to make, and it's based on data. So as Nadia said, it needs to be done in a way that is timely, so we don't deny patients from care. Like for instance, any medication, vaccine that comes in needs to be licensed. Yeah, it takes months. But they can do it. Like for instance, COVID-19 vaccines that are coming in, you have to do it fast. So that this is something that standards that we have and we need to improve on. Okay, what was the next question? Preventative medicine, yes. So that's Ministry of Health's role. My area is public health. So it's public health practitioners' roles. Yes, we are looking at wellness, but private healthcare is not. Because as we talked about it, private health insurance only covers hospital cares. We have a lot of GPs, but they are not covered by insurance, and patients are going there. It's not like a family doctor concept. It's not follow-up to a doctor. It's not a primary care physician that's seeing them. It's a GP. A lot of times it's locum. So you don't have regular screenings. You don't have proper treatment, management of chronic diseases. These things cannot be treated at hospital level. They should be treated early at healthcare. In fact, we call about primordial prevention. As in, before you're sick, before you know you're sick, you're already preventing a disease, before the disease is even born. Okay, so this is health promotion. So it's actually being done in Ministry of Health facilities, but the chronic underinvestment of our facilities, the lack of manpower, the lack of digital healthcare that we could use to harness information to provide promotion materials and so on. This is where we need to invest in. Okay, I think I want to answer one more question. We're talking about health reform and health financing reform. So I just want to say that there is not just one way that fits every country. Every country is individualized. Malaysia is not Singapore, it's not Thailand, it's not Indonesia, it's not Taiwan, it's not Japan. We need to develop something, a financing model that works for us, for working for our healthcare system, which we know is mixed public-private, working for people, a population. You know what was the number of people who actually pay tax? Yes, okay, so YB has the figures right at hand. So government contribution to health financing should not stop and actually should increase. But there should be other mechanisms for financing, and this is what we're talking about, social health insurance. But it's not the only method of financing. So this is something that we need to develop and get buy-in from the public, because government financing is not enough. And private health insurance is just a stopgap, and it seems that it's going to be more and more elitist.
I have a few points. One is, like, where is the money going to come from? When you think about the issue of new funds being needed, consider the fact that there has been calls for a reinstatement of GST instead of SST. Because SST collects far less revenue compared to GST. GST, when it was collecting around 44 billion. SST in 2021 collected around 27 billion. So we've given ourselves a discount because, you know, of course there's a political dimension to it, but the fact is that there is now a discussion amongst economists, and even dare say at the Ministry of Finance, is that maybe we should put back the GST because we're not getting enough revenue. It's not a great conversation to have with politicians because it's not politically palatable, right, to have GST back. But consider that even that conversation is very tricky. And here we are talking about new funding for health specifically. But it is possible, I think. It is possible to have that. Second point is concerning EPF. People, when they talk about EPF, they think it's this mega pool of funds, you know. Yes, it is. EPF is actually one of the biggest funds for employees in the world. It's I think around 200 billion ringgit, I think, in the world. But you know who has the majority of that contribution? 10% of those who contributed. 90% of contributors to EPF actually do not make enough to save for retirement. By the time they hit retirement, they're going to be in poverty, which means they're going to have less than 240,000 ringgit in their account, because people are not contributing enough to EPF. So yes, we have a lot of money in EPF, but whose money is it? And this is where it becomes a problem because we're not contributing enough. There's not enough money going to EPF. And EPF will hate it yet again. We're talking about withdrawing from EPF. Because the ones who are going to be withdrawing is going to be a small group of people. It's not going to be everyone. So what we say is that when it comes to EPF, let's add on, not take on from existing. But even then, not everybody is paying EPF or contributing EPF. How about those who don't? So we have to figure it out, and therein lies the problem there. Drugs, I think there was a question concerning medicine, price controls, and transparency. I mentioned just now about the hospital bill. The hospital bill is like 20% of your hospital bill. The contribution to your hospital bill doesn't come primarily from the drug prices. It comes from other things. And one of the issues concerning transparency is this suggestion that you should make transparent the prices of drugs at the hospital or healthcare facility. When you go to a healthcare facility, are you going to be looking at the prices of drugs like you go to a restaurant and buying nasi goreng Pattaya or nasi, well, I shouldn't be eating that, like, it's not healthy, right? But, you know, like you're ordering food at a restaurant before you go into the hospital. No, right? You go in with the belief that you're going to get the care that you need at that hospital, the best possible care, and that you'll be charged later. So you'll see that charges later, but you won't see it at the beginning. So I'm not entirely sure having the prices of these drugs at the front of the hospital is going to achieve anything other than increase regulatory compliance costs and so forth. But also it's like a tick in the box and say, yeah, you know. So I'm not entirely sure how that actually works to the benefit. And definitely when you look at price controls, Malaysia is an upper middle income country, 2,000 US dollars less than high income status. We are about to become high income. Once we become high income status, everything changes. The cost of everything changes. Even going to a conference for us is going to cost more because we come from a so-called rich country. Yeah, lah, academic, you know, we all know lah, that's right. And then finally, I wanted to mention that, and this is going to be a little bit sensitive lah because we're in Universiti Malaya, right? Economic realities must be acknowledged. When the prices of consumables go up, when the cost of retaining healthcare professionals go up, when you're competing against other institutions for the best talent, for the best nurses, specialists, medical officers, and so forth, costs go up. When the US dollar increases in strength against ringgit, things go up. And so we need to ensure that we're able to adjust, but also maintain that affordability, but at the same time manage that properly. But the problem here is this, and I say this to Universiti Malaya, it has just been announced that UMMC has just revised its fees. For example, beginning this year, it has now increased the fees for consultation and ward admission for the public university, increased from between 150 and 233%. So even for Universiti Malaya Medical Center also, they're not immune to the economic pressures as well. It's not just about private hospitals or insurance and some of them. These are the economic realities that we have to deal with as a country that is an upper middle income country with economy and purchasing power such as it is. But we also need to ensure that the conversation shifts from we cannot afford it to how can we make sure we can afford it. The conversation must change from this very poor way of managing costs, looking at budget lines, to not increasing the amount of money that we have. We have to find a better way to have these conversations.
Thank you. So we're going to go to YB. You have a number of questions to answer as well. And then after that, we're going to do a quick 2-minute wrap-up for everyone. And we'll still be around to have some questions and answers with you guys off the stage. But obviously, we've run 1 hour over time. Earlier, we were sitting in the holding room and we were discussing that if we sat here for 24 hours, we'll still skim just the surface of this. But, YB.
Okay, I want to answer on this, what they call pharmaceuticals and medicine. Okay, I think the Prime Minister has actually in the Parliament answered certain question. Actually, the Prime Minister actually is exploring to buy more generic drugs, okay? And then he wants to dismantle monopoly, okay? And he also wants to have a strategic purchase, so to lower down the cost. This is announced in Parliament. So I think this is part of the MOH reform to try to control the cost at the medicine in the public hospital. I'm not too sure about the private hospitals. And then on this insurance, I think I like your question and your what you raised about, you know, insurance is it's like MLM lah, you know, selling, and then the agents are having charges that, you know, they got commissions. So these are, when I posted on this healthcare insurance things on my social media, a lot of people raised this up in my social media. They said, hey, we have to look at the agents as well with their trips to overseas, incentive, etc. I think Bank Negara Malaysia, I want to shout out to Bank Negara Malaysia lah. They have to look at this, okay? This is, they have to regulate, they have to make sure that there's no, more regulations on insurance companies, their practices. Actually, there are a lot of innovative, solutions on, for example, online, okay? I think, for example, 20 years ago, I live in America, okay? I buy my car insurance online. I don't need an agent to get and it's very easily comparable which company give you the best quotes, premiums. No need. Why not? We do this. I mean, this is 25 years from now with all the technology and AI. Why can't we buy insurance online? Okay, without having more creative lah to solve this problem. And then second is this issues of overdoing procedures, over investigations, and unnecessary admissions. This is happening, okay? Some requested by the patients, but some are doctors, okay? Doctors decide whether you need to check this or not. He recommended, okay, you have, first thing we go to hospital, what do they ask? Do you have an insurance? Do you have an insurance? If you have insurance, you have all kinds of things. I don't know, is it necessary? May not be necessary. And this is like America. Do you have an insurance before you go? You know? So this is overcharging, over procedures, over investigation, and unnecessary admission has to be looked into. This is where the regulatory regulations must come in. Now we have no regulations. No regulatory framework. There's no authority to look into this. That's where I think the PAC and we will be focusing on these issues. Okay, on I think preventive, and I think DRG. Okay, DRG is one way of payment, but this is not a silver bullet. Okay, DRG Malaysia, we should have a DRG for Malaysia, because we cannot compare the Singapore cost. We then cannot compare on the US or UK cost. It has to be a Malaysia. That's why the database, the data must be transparent, must be good, so that we can implement DRG in a most cost-effective way. And this is only part of the solutions, not the entire solutions. I agree to all the panels. Okay, maybe I can do the wrap-up. 2 minutes. I think we need to look at this healthcare funding, private healthcare, public healthcare in totality, in a whole ecosystem. And to reform it, there needs to be political will. There needs to be a lot of consensus. I agree with Professor. It has to be Malaysia-based. There's no one single bullet, silver bullet from US we can copy. No. From even Singapore, we cannot copy. Okay? It has to be Malaysia. What works for us? What is the best? So far, I want to say the credit, actually the private hospital, public hospital, so far is quite a working system until several months ago where all the insurance and the prices goes up. So far it works. But now we need to look carefully where we go. And I think there are success stories, okay? The success stories is because the public uproar, okay? The media, including Sinchu, FMT, and the presence here, the Scoop, and also Sina Harian and Berita Harian, really go after this issue. And the members of parliament like me pick up this issue. And we really raise it up very aggressively in the parliament. You can see that I have done more than six press conference to pressure on this issue. Then the government works. The Bank Negara intervene. The Bank Negara comes in and regulate. Okay? I think that is where I think the good thing about the Prime Minister, Bank Negara, and the Ministry of Finance, the response to the rakyat. That is very different. That is very, very different. And they acted very fast. And Prime Minister, in his Prime Minister question time, immediately just fly in from overseas, he responded to this issue. So this issue quickly resolved. I think we need this kind of leadership and political will to address bigger issue, which is the fundamental, which is the more difficult part, which is the rising cost of private healthcare and the costing, not only private healthcare, but also public healthcare, because the cost escalation cuts across everyone. So now, I want to shout out to everyone here. The fight is long. We have to be vigilant. Today, maybe we win some battles, but the system will fight back. The for-profit organization will continue to try to squeeze whatever profit that you can get out. So it is a long fight. Today, I can fight. The next generation of members of parliament, the next generation of doctors and specialists, professors must fight back. Okay? I think hopefully we have a more Malaysian way of, we have to find Malaysia formula, Malaysia's formula to address our healthcare. And let's work together. Thank you.
Azrul, any final thoughts from your side? We'll come down the panel here this way. Yeah.
Okay. I just wanted to mention that when you look at the history of the NHS, the National Health Service in the UK, it took around 7 years to get that set up. And it was after the Second World War. Think about it. If you want to think about the worst possible situation, that was pretty much what I would like to say is that it's not impossible for us to do. And we need to be taking this issue seriously. We need to be realistic and pragmatic. We need to engage politicians like YB Sim here. And as mentioned just now, it needs to be across the aisle. It must be a bipartisan issue. This is not an issue for one particular party. It is for all Malaysians. And it is in the best interest that we get the possible solution there. I wanted to also just very quickly say, nobody goes to a private hospital for vacation, and then you go there and then you start selecting, I want to go for this, that, and everything. No. I want to make full use of my insurance. No, nobody does that. But you are on basically sometimes the worst day of your life, and you want to be able to be cared and treated, and you want to get that, And it should be accessible to everyone, not just people who pay insurance, but also others as well. But for those who are today, when they're looking at insurance today, there are quite a number of issues that we also have to make honest reflections. Even the 10% cap for 3 years that was negotiated recently, you have to ask yourself the question, what happens after the 3 years? Exactly, yeah. Is it going to suddenly come down like a ton of bricks? We're going to get more. So there are a number of issues here. We have to find sustainable solutions, but also pragmatic and realistic solutions. And we cannot shy away from tough decisions. Things like the generic policy, Malaysia actually has a generic first policy already. More than, 70, 80% of Malaysia's drug supply usage are generics already. And we're reserving the use of innovative drugs and so forth for those drugs that have no biosimilar or generic equivalent. So Malaysia, thankfully, has already adopted that policy. But the issue here is sometimes managing budgets rather than expanding the budget. We need more money at the end of the day. And this is something that we need allies, both in this government and future governments. And as what was mentioned just now by YBC, it's a marathon. It's not a sprint. It's not going to be done this year. It's not going to be done next year. We need everybody to be involved, consulted, and engaged. Thank you.
Thank you. Nadia?
I'll start off with the big picture. I think, you know, we're talking about healthy behaviors. Since YB, you're here, I'm putting on my public health hat. We also need healthier cities. We need clean air, clean water. All of this affects health. If people are not mobile, you can't expect them to be healthy. So I think there's a lot of things outside the Ministry of Health that, frankly, you know, any government needs to look into. And my wish is that in the future, if we pick a random Malaysian off the street and you ask them, how is their health? They would have done a screening. They know their parameters. They know what they need to do to manage. And this can only be done through primary and community health, which needs to be funded. Because right now, the providers are predominantly in the private sector, and the funding is not there for that. There needs to be an understanding, definitely from the private hospitals, the doctors and the consumers, that private healthcare in Malaysia, because we are such a unique country and system, it's not about a supplementary system. It is a core part of the healthcare delivery to the population. And so we are part of a social objective. And in the long run, I'm afraid, I think the cost will still go up. But I think the question we need to ask ourselves is, what do we get for the money? And these are all the things that we're discussing, DRG and primary health and all that is, if we know that the cost is inevitably going to go up with inflation and whatnot, how do we make sure that we get the best value out of what we pay for? And I think that we had a very good example during COVID where we all came together and worked together. We can if we want. It was an extraordinary time, but I hope that we don't have to wait for the next global pandemic in order for people to get up and say, like, something needs to change. Thank you.
Prof. Tarani?
But the thing I would like to add is a call of action for all the participants here. So having this kind of public discussion, public engagement, multi-stakeholder panels is actually a very good thing. And it's good for our Malaysian population, good for Malaysian discourse, and it helps our opinions to go to the leaders, okay, and decisions to be made. We should actually engage more with what we need and demand for more change. Our healthcare system is for us, but this is only one of the crises that we are facing that's showing its shortfalls. COVID-19 was a major crisis, and I think we've forgotten. Yeah. We've forgotten, okay? There are a lot of untold stories here in this room as well, or in our country. I mean, of people facing financial toxicity for cancer, you know? Yes, we have public hospitals, but sometimes you want the best care, what best possible outcomes for your disease. You go to private hospital, and frankly, you can't afford it. Or your insurance does not cover. So this is the real stories that's facing Malaysians today. And we can't wait until it happens to us or to our family members before we react. Yeah. So I'm glad we're having discussion. We should engage more.
Anything to add? Okay, so takeaway points from just now. From Azrul over there, your medical insurance policy is not a license to go to a private hospital and have a vacation. Right? Simple. From Nadia there, she's talking about the cost of healthcare is going to go up. But it's a whole of society problem. It's not only the sick people's problem. It's not only the taxpayers' problem. Because if you're looking at the data right now, 2.6 million people are actually funding 45 billion ringgit into the healthcare system. It's not sustainable. If there's more of us doing this, then, there's something to go on. Prof. Tarani is talking about all of us being responsible for our healthcare, right? And YB Sim was talking about us continuously having these kind of engagements to bring up this awareness so that everyone is aware of this and always be engaging with our government.